Morning.
Good morning.
Someone with me? Hello?
Yeah, hi. Hi, this is John Bennett. Who am I speaking to?
Hello, John. I am Walid Abdelghani. I
Hi.
have a presentation, I think, after a few minutes.
Oh, good. Good for you. Okay, you know how to screen share and everything, right?
Yeah,
Okay, do you have any videos?
yes. Can I
Okay.
test it?
Okay, yeah, let's test it. Good idea.
Can I share now?
Yes.
Okay. Uh, can you see my screen?
Yes.
Okay. Okay. This is
Okay.
my first slide.
Okay, let's see the videos.
Okay. And this is first video.
Okay.
Is it running?
Yes,
Okay.
it seems okay. But let me just let you be aware it's possible it won't work well because the bandwidth is not very good there. So
Ah,
don't be surprised if it does not work well. If it does not, just please move on. Okay.
okay. Uh,
Okay. Hopefully we'll get lucky and it'll work fine.
there is another videos. We'll test it.
Yeah, they all seem to be okay. They all seem good. Good. Very good. Maybe it'll work well. Just be aware. That's all.
Okay.
Most of the time, there's no problem.
This is another one.
Works well.
Okay.
No foot drop.
Yeah. And good knee flexion and in the swing phase.
Yeah, good part of your presentation's video.
Yes, it's almost all videos.
Oh, okay, that's fine. Maybe they're a low bandwidth video. Do you know what I mean? They don't seem to be using much
Mm,
bandwidth.
mm.
Okay, you can get off the
Okay.
slides here. It looks
Okay.
good. Let's give it a good shot.
Okay.
You're the
So
first presenter? You're the first presenter?
no, maybe the second.
Okay, I'll let the moderator introduce whoever is going to speak.
Okay.
Okay, nice meeting you.
Thank you, John.
Okay,
Seems it's late in your time.
yeah, but I used to work as a doctor, so I know what it's like.
Okay.
And for me, it's just once in a while. It's not regular, like a doctor.
Okay.
Like you, I'm sure there's some nights you're up all night, right?
Again, please.
I'm sure there are nights and when you are up all night.
No, it's now on my time. It's 7:25 a.m.
Okay, but when you work, sometimes you work all night, right?
Yes, yes, yes. This is usual.
Yeah, yeah. So the doctors understand what it's like to be up at night.
Yeah.
I tried to sleep during the day. You know how that is. Trying to get rest before your shift. But
Yes,
sometimes it's a little difficult to sleep because the world doesn't revolve around doctors.
I understand. Yes. So when you start, will give me a
Yeah,
notification.
we'll let you know. Yeah, well, the moderator will come hopefully in a few minutes.
Okay.
Okay,
Okay, sir.
I'll see you in a little bit.
Thank you.
You're welcome. Who is starting? Has the first presentation? Is the first presenter here now? I know Walid's doing a second one at 8:50. Who is doing it at 8:30? Well, I could easily look that up. You guys will be able to see this. Capuano, Christian Capuano. That's who I'm looking for. Are you there, Christian? Hello, are you there, Christian? Hi, Muhammad. Muhammad Shams. Can you unmute yourself? Your Zoom is muted. Your Zoom is muted. You need to unmute your Zoom. Muhammad. There you go. Okay, can you hear me, Muhammad?
Yes.
Okay. You can hear me okay. Okay, the first speaker is, you're going to moderate, Muhammad? Hello? Okay, good morning. Who's the moderator? Is that you, Muhammad?
Yes.
Hi, Muhammad. How you doing this morning? Okay, Muhammad is who should I introduce as the moderator? Is there a moderator? Hello? Yeah. Who is the moderator?
So good morning, June. Me, Dr. Khalid Swailim, and Dr. Mujahid Maisar, the moderators in the session.
Oh, okay. Let me see you. Where's your picture? I don't see you. Hello. Can you introduce yourself, please?
Good morning.
Okay. And your full name, sir? Your full name, Muhammad?
Good morning, Dr. Muhammad Shamsuddin.
Oh, okay. Okay,
Yes.
I'll introduce you first, okay?
Yes. Dr. Muhammad Shamsuddin, neurosurgeon, head of department of
Wait. We haven't started yet. Are you ready to start?
Yes. It's our
Okay,
time.
you need to put your face in the picture. Your face is off the camera.
This is our connection.
Move the camera. I can't see your face. Can you move the camera up? I want to see your face.
Yes,
There.
yes, this is our IT.
Okay. Okay, are you ready, Mohammed?
Yes, I am ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett recording from Miami Beach, home of Neurosurgical TV. I'd like to introduce a full day of conference today, and we have Mohammed moderating. Okay, Mohammed, it's all yours.
Yes, yes, I am ready.
Okay, could you please introduce yourself?
I am Dr. Muhammad Shamsuddin, neurosurgeon, head of Neurosurgery department at 48 Modern Hospital, Sana'a.
Welcome.
Yes, my lecture about endoscopic third ventricular third ventriculostomy. Okay.
Perfect.
Yes. Third ventriculostomy consists of opening of the floor of the third ventricle through a lateral ventricle and the foramen of Monro. Now one of the surgical procedure suggested for the treatment of obstructive triventricular hydrocephalus in children and adults. In the literature, overall success ranges from 8% in very young children under 6 months of age to 100% in hydrocephalus secondary to supracellular cysts or tectal tumors. But in most cases, the average success rate is 70%. In case of shunt dysfunction, this patient may expect success rate triventriculostomy range from 27 to 80%. The purpose of this retrospective study is analysis the efficacy of triventriculostomy in pediatric population in mono institutional and analyze the prognostic value of the age and etiology. In patient undergoing third ventriculostomy as a surgical procedure, first choice primary group following ventricular peritoneal shunt secondary group. Background, neuroendoscopy began in the 1900th century with the first attempt to treat primary hydrocephalus in children. In 1010, Spain and others, coagulation of choroid plexus. 1921, Walter Dandy stomy on the terminal lamina by craniotomy. 1923, Fay and Grant ostomy between lateral ventricle and precallosal subarachnoid space through the corpus callosum, and first black and white photography of the lateral ventricle. Maxter was the first to perform an endoscopic third ventriculostomy. 1930 to 1960, Scarf perfects the endoscopic instruments. Fukushima uses the first flexible fiber optic endoscopy. Next. In third ventricle, anatomical landmark. We have here septal vein, thalamic striated vein. We have the choroid plexus. The foramen of Monro is a space between the pillars of the fornix and the anterior ball of the thalamus. The foramen of Monro represents an important point of venous confluence where the thalamus striated and caudate vein of the lateral group, and the anterior and posterior choroid and septal vein of the medial group. Third ventricle. Sagittal section of the third ventricle. The floor extends from the optic chiasma to the Sylvian aqueduct, and include the lower part of the chiasma, the infundibulum, the fundibular recess, the pituitary gland, tuber, sternum, and mammillary body. Material and method. This study, it was from 1994 to 2004. 353 procedures in 308 patients. Female, they were 148, male 180. All patients underwent MRI before surgery. The same MRI study was performed in elective patient scheduled surgical procedures. This is one in etiology of the third ventriculostomy, aqueduct stenosis, column tumor of the posterior fossa, aqueduct stenosis, malformation, Chiari, anomaly, outlets, stenosis, fourth ventricle, post-hemorrhagic hydrocephalus with aqueductal stenosis, tumor, pineal region. Distribution for age. The study was from 0 to 12 months. We have 91 patients. More than 1 year to 5 years, 76 patients. From 6 years to 10, 50 patients. 11 to 15 years, 60 patients. More than 15 years, 51. The age of surgery ranged from 1 day to 18 years, average 104 months. A peak incidence was observed during the first year of life with 91 patients, 27.7%. Etiology for hydrocephalus. Excuse me, this slide from in Italian language, but okay, we can understand it. Aqueduct stenosis, okay. 93 patient, tumor, 84 patient, fourth ventricle, 63 patient, post-hemorrhagic, 55 patient, post-infection, 14, cysts, 13, post-traumatic, 3 patients. And we have 2 groups here for third ventriculostomy, primary, and second group for third ventriculostomy, secondary. Okay. First group, first choice surgery, third ventriculostomy. Second group carried out for shunt dysfunction in children, previously underwent VV shunt. VV shunt removed immediately after third ventriculostomy in all cases. Age distribution in group 1 and 2. Group 1, ventriculostomy primary, they were 225 the second, they were 103. Okay. From 0 to 12 months, the result was 67%. More than 12 months, 32%. Patients were shunted before and dysfunction this shunt. They were 86 patients and 70. Etiology for the first group and second group. Aqueduct stenosis in first group 72, tumor 71, ventricular 36, post-hemorrhagic 33, post-infection 5 patient, CIS 7, post-traumatic 1. Aqueduct stenosis and tumor hydrocephalus are more frequent in group 1, okay, 32% and 31% respectively. Then in group 2, 20.4% and 12.6%. Post-hemorrhagic and post-infection hydrocephalus are more frequent in group 2, 21.3% and 8.7% respectively. Then in group 1, 14.7% and 2.2%. Preparation for operation, neuroendoscopy and instrument for endoscopy. Rigid, this in this photo, and this is flexible. In the present cases, series, a rigid endoscopy with 30-angled optic has always been used. We have here equipment necessary for endoscopy. There is not sterilized equipment and there is sterilized. The sterilized equipment in the trolley. Monitor system of camera, cold source, suction, irrigation, high frequency generator, and video registrator. This is sterilized instrument. The instrument that need to be sterilized. This is a cable for light transmission. This is the neuroendoscopic 10.5 French, 9.5 French, 9 French. Al-figure T, this is balloon that for stomy, and this is for coagulation. The operative technique, before the incision, assemble the endoscope and check its correct function. Skin incision, a drill hole in the right frontal region in front of the coronal suture and 2 centimeters lateral to the midline. Easily approach the frontal horn of the lateral ventricle, and once the foramen of Monro has been visualized, where the choroid plexus, the thalamic striate vein, and the biliary of the fornix are clearly visible, to enter third ventricle where we can, or they can. This is a floor of the third ventricle, a target here. We have here mammillary body here, and this is the target, and this is rectus infundibular. The floor of the third ventricle, where Fenestration is performed in the midline anterior to the two mammillary body and posterior to the infundibular recess at the point farthest possible from the basilar artery. Basilar artery, it will be here. This is the stomy. Fenestration is most commonly done or by simple pressure in the ventricle floor and the enough of or the monopolar coagulation. Once the stomy is performed, the fenestration is progressively dilated by means of the Figerty catheter. The stomy is already dilated here. The interpedicular cisterns here, and we will visualize the basilar artery. At the end, the endoscope is removed through the same corticectomy. Used the introduction and the periosteum and the skin layers are sutured. This is a movie. Here we will arrive the foramen of Monro, septal vein. We will enter the third ventricular fornix. Mammillary body, dorsum cellare. Hypophysa. This is our target here, but this is pulsation for the our target, the pulsation for the basilar artery. اوكي يختار يشام جديد هاي مشي خلاه 3 minutes من جديد في سحب بعد شويه We will start yes again. Yes. Mammillary bodies. This is our target here. There is pulsation. So we will do it here. This is coagulatory. For stomy, after that, we will insert balloon. Insert. This balloon. Pulsation, that means the flow is good. Clavus. Basilar artery here. Okay. That means the flow is good. Other. Next. Next, from here. Yes. This is complication. There is a little complication, not a lot, 9%. It was like venous hemorrhage or intraventricular or intraparenchymal, CSF leakage, or surgical ward, 2%, 1% local infection, 0.6% subdural hygroma. This is without complication. Conclusion: 3 ventriculostomy as a first choice procedures and the treatment of obstructive hydrocephalus. 3 ventriculostomy as a valid alternative to revision in previously treated subjects with shunt dysfunction. That means previously patients were shunted. After that, dysfunction for shunt. This is object for third ventriculostomy. Best result in group 1. That means patient from 0 to 12 months. Worst outcome in children more than 1 year of age. Conclusions to the ideal candidate for third ventriculostomy is a subject of at least 1 year of age suffering from hydrocephalus, obstructive due to aqueduct and tumor stenosis, submitted to third ventriculostomy as first choice, estimated result 90%. Thank you. Shams. Okay. Excuse me?
Yes, I believe Walid is up, correct?
Yes. Good morning.
Okay, can someone introduce Walid, please? Hello, Mohammed.
Yes.
Could you introduce Walid, please? For the next speaker.
Yes. Where is it? Walid. Where is Walid?
Okay, no question. Thank you very much. We shift now to the second speaker.
Yes.
Dr. Professor Walid Abdul Ghani from Egypt. He's a professor in neurosurgery at Ain Shams University. Can we start, Dr. Abdul Ghani?
Thank you.
Dr. John?
Thank you for inviting me for this excellent and well-organized meeting. I am Walid Abdul Ghani from Egypt. I'm a professor of neurosurgery and the director of Movement Disorder Clinic at Ain Shams University. My talk today will be about the central and peripheral ablative procedures for hypertonia, especially in pediatric age group. I have no disclosures. My objectives today is to justify and clarify the role of neurosurgical ablative procedures in the management of hypertonias regarding the indications, techniques, and the outcome. When we estimate the role of functional neurosurgery for functional disorders, we find that neurosurgery for hypertonia is underestimated. This graph shows the national American database regarding the functional disorders, including chronic pain syndromes, Parkinson's disease, epilepsy, in comparison to the other movement disorders associated with cerebral palsy, spinal cord injury, stroke, MS, and the neurodegenerative disorders. We find that the procedures for the movement disorders, especially the hypertonia, is much less estimated, despite of being very effective. Let's see this video for ambulatory cerebral palsy girl. This pattern is what we can see in a growing child with cerebral palsy. We have two extremes, either functioning ambulatory or, on the other hand, the non-ambulatory. We can estimate the impact of hypertonia on both sides. In the left side, the girl grow with miserable malalignment and many rotational deformities in lower limbs. In the picture in the right side, for a boy with severe disability affecting the whole of the body, and the impact of hypertonia resulted in this severe form of joint and muscle shortening and deformity, if kept untreated. As a neurosurgeons and functional neurosurgeons, we know that there is many pathology either in the brain or spinal cord affecting the development and prognosis of hypertonia. In this kid with a generalized form of hypertonia, we can see the impact of spasticity and dystonia. If present together, it will be mixed hypertonia. And this hypertonia in the presence of musculoskeletal changes associated with the upper motor neuron lesions are resulted in a force called the torque. The torque is the sum of forces which imposed on the growing skeleton, either by the hypertonia or by the local changes in the muscle and skeleton. This force may result in deformity in the axial skeleton, resulting in scoliosis or pelvic obliquity, or in the peripheral skeleton, resulted in rotational deformities and joint dislocation. In 2013, an Australian group made this magnificent systematic review regarding the interventions for children with cerebral palsy, and they addressed the state of evidence. In about 164 publications, included about 64 procedures for management of cerebral palsy disability. They concluded and gave light traffic colors for those procedures with high evidence. We have the green color for the procedures which is mostly effective and should be done for almost all people with or children with cerebral palsy. The first of them was the tone controlling procedures like botulinum toxin, rhizotomy, or some medications for lowering. Others like casting, hip surgery, some physical therapy techniques, and bisphosphonates to improve bone density, and to care about the pressure sores and ulcers, and the anticonvulsants to control seizure, which is an indirect cause for deterioration of motor function in children with cerebral palsy. Most of procedures had a moderate or low level of evidence, and we should think before applying it to children with cerebral palsy spasticity, like baclofen, oral baclofen, or intrathecal baclofen, or some orthopedic techniques like hand surgery, or some procedures like the single event multi-level soft tissue lengthening, and many others techniques. And about 6% of these procedures have no rule or have not yet estimated as a a useful procedures for management of hypertonia or spasticity hypertonia, like the craniosacral therapy, hip bracing, hyperbaric oxygen, neurodevelopmental training, and sensory integration. Actually, in cerebral, in hypertonia, we are managing the sequelae or consequences of the upper motor neuron lesion. We have, among the literature, we have studied the upper motor neuron lesion consequences in two patterns: either the vertical pattern, it means that upper motor neuron lesion resulted in spasticity, which in turn resulted in muscle stiffness, and this muscle stiffness lead to bone deformity and joint deformity. Actually, this is not the real situation. The real situation is we have all the procedures running at the same time. When we have an upper motor neuron lesion, spasticity started, muscle stiffness is going on, and deformity started. So we have to treat from the day zero. We don't have to wait until muscle stiffness and bone deformity occurs. Cerebral palsy hypertonia, we have studied the progress and the development of the gross motor function among children and youth with cerebral palsy. We found that according to the gross motor function classification for cerebral palsy function, those kids with motor function or gross motor function level 1 and 2 usually developed and gain the ambulatory function by the age of 5, and they can sustain this function among the years later on. But those with gross motor function 3, 4, and 5 are liable for regression and deterioration of their motor abilities by time due to growth and the impact of deformity on the ambulatory level. So we have to introduce our management as early as we can. The timing of interventions in cerebral palsy hypertonia is determined by mostly by the age. We can find that in early years of life, we mostly can apply the tone management procedures, like either medications, like botulinum toxin injections, or neurosurgical ablative procedures. And by time, we find that the inevitable changes that happened in the tendons and muscles and bone make the orthopedic intervention mandatory, either alone or in conjoined with the neurosurgical procedures at the same time. Neurosurgery, we have an armamentarium of techniques started with simple procedures like the physical therapy, botulinum toxin injection, simple tendon lengthening. In more severe cases, we can apply the neuroablative procedures like combined rhizotomy, the selective dorsal rhizotomy, selective peripheral neurotomy, rhizotomy, median myelotomy, and some orthopedic techniques like tendon transfer and advanced physical therapy techniques. And recently, we have an elegant neuromodulation techniques which can help much for motor development, like the intrathecal baclofen, deep brain stimulation, and spinal cord stimulation, and some corrective osteotomies and the orthopedic surgery to correct the lever arm dysfunction, and the high technology physical therapy techniques like the robotic rehabilitation. Regarding the rhizotomy and myelotomy, both have good impact on reducing muscle tone, beside its role in controlling severe chronic pain syndromes. It's indicated in painful paraplegias, hemiplegias, and as we know that rhizotomy for cerebral palsy was introduced in 1976 by Marc Sindou in Lyon, France. This graph, we can show the site where we can do the myelotomy. It's done in the central sulcus in the spinal cord up to the central canal to disconnect the crossing fibers between the both sides and decrease the hypertonia in both lower limbs. Regarding the rhizotomy or dorsal root entry zone ablation, it's done in this area by many techniques, either the radio frequency or microsurgical techniques or laser techniques in some institutions. And we introduced the lesioning probe in 45 degrees to the midline to 1 or 2 or 3 millimeters in depth, and we interrupt the cells or myotatic fibers in the dorsal horn and dorsal root entry zone. In 1932, Sir Charles Scott and Edgar Douglas have their Nobel Prize regarding their discoveries in the functions of neurons. Actually, they discovered the pathway for tone control and the rule of how could the spasticity developed in their work on the cerebrated cats, where they cut the dorsal roots and find that it results in hypotonia after deceleration or spinal cord injury in cats. Actually, this man was the real introducer of our procedures, which is called the dorsal rhizotomy. In 2016, we in CHAMS published this technique regarding the combination of the anterior and posterior lumbar rhizotomy for treatment of mixed dystonia and spasticity in children with cerebral palsy, as we found that not all children with mixed hypertonias got benefit from sectioning of the dorsal root only. So we have to combine the anterior and posterior root resections selectively and based on quantitative and qualitative measurements to control both arms of the reflex arc, especially in dystonia. When we revise the pathways for controlling motor function in the brain, spinal cord, we find that spasticity is a monosynaptic stretch reflex arc, which is easily identifiable and easily targeted, while dystonia, as we can see, this very sophisticated interactions and controls between neurons make the management of dystonia is somewhat difficult and maybe disappointing in some circumstances. It's important to differentiate between type of hypertonia in cerebral palsy or any other types of pathologies, because the choice of treatment could be based on or could be directed according to the prevalence of one or one type or more of these hypertonias. As we mentioned before, spasticity could be easily treated relatively and as if compared with mixed hypertonias or dystonias. So we should evaluate the hypertonia very carefully, and we can measure the presence or justify the presence of other types of hypertonia at the same time. Actually, we have predictors of poor outcome. After that's what we can say after the selective rhizotomy. Not all children get benefit from. Why? Because there is a predictors like the diagnosis of type of CP hypertonia. Selective dorsal rhizotomy is working better for people with or for children with cerebral palsy spasticity rather than mixed forms of hypertonia. Actually, also the intellectual level and mental performance made the motor learning better in those children with good IQ level. Rhizotomy is done in the roots at two levels, either at the conus level through 1 or 2 levels laminotomies, or at the exit foramina through multi-level laminotomies. We can do the selective dorsal rhizotomy only in cases of spasticity, or combined anterior and posterior rhizotomy in cases of mixed hypertonia. Our goal is to improve the ambulatory function, improve the caregiving for those with severe form of disability, and prevent or control the development and the progress of severe forms of deformity like this boy. Technique of rhizotomy is done in prone position and under complete operative neurophysiological monitoring and EMG recording, especially from sphincters. We adopt this technique in Ain Shams. We do multi-level laminoplastic flap and open the dura. I hope this video is running well. We open the dura, we identify the roots at the exit foramina, and we dissect the anterior root from the posterior root, and we made mapping by the stimulation and recording from the muscles, and we made an interpretation of the amplitude of response and pattern of response, and then we did the selective resection. Also, it's important to identify any responses from the pelvic floor muscles and anal sphincters. And this are example of recordings, and then we can coagulate and do the resections. And some cases for demonstrations. This is a 3-year-old girl with spastic diplegia. It's gross motor function level 3, walk with assistance. And this is 15 days just post-operative selective rhizotomy. We can compare the gait pattern in between two sides. In left side, she is two walker, and in the right side, she had good heel contact and good reciprocation pattern. This is just after 15 days of surgery. And this case is an 8-year-old girl with stiff knee gait pattern and equinus gait. And this is just 6 months, I think, after the surgery. She had good reciprocation, good knee flexion in mid-swing phase, and good heel contact in the ground, and more stable gait. And this is the curves for gait lab. Another boy. This boy has mixed form of hypertonia, spasticity, and dystonia. And this is after 18 months of surgery. He is now an independent ambulator. He's going intensive physical therapy, and he can move alone in good pattern with good balance in comparison to the preoperative condition. All these procedures does not require an orthopedic techniques after we are doing the rhizotomy. And this is another case. We can, for the sake of time, we can go for the next. This is an 5-year-old boy with more generalized form of dystonia affecting all body parts. He underwent combined rhizotomy, and this is 1 year post-operative. He can maintain sitting position, and we can, and this is after 1 year and a half, can sit more comfortably, and we can notice his upper limb also occur. This is known as the suprasegmental effect of rhizotomy, that the upper segments respond well to the also to rhizotomy. This couldn't be explained by the direct effect of rhizotomy, but maybe by the neuroplasticity and improving motor function in the brain. Also in adults, fortunately, this is a Yemeni patient with spinal cord injury, and this is he had very severe form of spastic dystonic hypertonia in both lower limbs. He couldn't do the gait patterns. And this is 3 months or 6 months after surgery. He can ambulate with assistance, with much less hypertonia and good independent walking. The beneficial long-term effect on gait parameters of these surgical techniques have a long-term very effectiveness on the gait parameters and pain reduction. Also, the reduction of rate of acquired musculoskeletal deformity and later on surgery, orthopedic surgery, and improve of function, participation, and quality of life. And this systematic or meta-analysis study confirm what we said about the effectiveness of selective dorsal rhizotomy and physical therapy on long-term basis. And regarding the post-operative spine status after rhizotomy and after multi-level laminotomies, we didn't find any drawbacks of doing multi-level laminotomies. All cases had good fusion and good spine alignment after surgery, maybe up to 10 years after surgery. This paper compared between the multi-level laminoplastic techniques versus the single-level laminoplastic technique, and they didn't find any significant differences. But maybe the multi-level technique are superior in preserving the sphincters and identifying the sacral roots more better. Also, we can consider this anatomical and functional fact discovered by the Professor Golgi, which is the Golgi tendon organ, which is present, the mechanoreceptor present in the myotendinous junction, that have an important role in controlling and in development of motor function, especially in children. This mechanoreceptor is very crucial, and any intervention regarding, or early intervention regarding tendon lengthening or tendon procedures before the age of 7 and development of gait patterns in the brain may affect it in very bad way. So we should limit or avoid any orthopedic interventions before the age of 7 and apply all neurosurgical techniques available. Regarding the other technique, which is a selective peripheral neurotomy, it's introduced to literature by Lawrence in 1887. It was an obturator neurectomy for patients with a spinal cord injury. Then its techniques is developed to had better outcome, which is done by selective microsurgical techniques under stimulation and monitoring. And the most famous paper discussing the 10 years follow-up by Mark Sandu in 1988, and stated that there is long-term effect of selective peripheral neurotomy to maintain muscle function. Selective peripheral neurotomy is done as distal as the motor nerve, when at the point of neuromuscular junction. We can sacrifice some fibers from the motor branch to the muscle, and it will be worked by the differential regeneration theory, where the motor fibers regenerate and the sensory fibers controlling the muscle spindle reflex regenerates in an disorganized way. This short video shows the technique for selective peripheral neurotomy for the soleal branch, or the motor branch to soleus muscles, a branch from the tibial nerve. Here we can open the neural sheath, perineural sheath, and open the fascicles and select some fascicles according to the stimulation parameters. And this girl, 3 years old girl, underwent the selective peripheral neurotomy. This is, or tibial neurotomy. This is preoperative. She had talibus equinus gait, and this is postoperative 2 or 3 months, she had good heel contact and improved level of ambulation. Hello?
Yes, Dr. Mujahid, por favor. Is he there? Dr. Mujahid, are you there? Okay. We need a moderator. Okay, maybe we need to ask a volunteer from the audience. Would anyone like to moderate this conference? I need a volunteer to moderate the conference because apparently no one's stepping up. Can you hear me okay, Waleed?
Yes.
Yeah.
I think you finished the presentation, or I still have some slides.
Oh, I'm sorry. Go ahead.
Thank you, Dr. Professor Waleed Abdel Ghani from Ain Shams University in Egypt for this nice presentation.
Okay, excuse me, sir. He hasn't finished his presentation. I'm sorry. I interrupted him. I'm sorry.
No, time is
Can
finished.
I continue, or?
Well, no. Do you mind if he finishes? I interrupted him. Go ahead,
more
Waleed.
Okay, you can continue, Dr. Waleed.
Okay.
Please
Instead
finish.
of
Please. I'm sorry. I interrupted.
Yeah. Dr. Waleed.
Yes, I'm with you. This is another child with multifocal form of hypertonia affecting hamstrings, calf muscles, and adductors. In this case, we combined orthopedic surgery in the form of tendon lengthening with selective peripheral neurotomies, and we can see the result. Also, we can combine the more sophisticated orthopedic surgery with selective peripheral neurotomy. And it could be done also for adults. This woman had the post-spinal cord spasticity affecting the calf muscles, and she underwent the selective tibial neurotomy with more stable gait and much balance. Also, it could be applied to the upper limb in such girl with post-stroke left hemiparesis. We can do it in the upper limb with good relaxation and good motor function of the hand. In Ain Shams University, we adopt this algorithm to manage the pediatric hypertonia depending on many scoring parameters, either physical, electrophysiological, or functional parameters, and we can place every type and degree of hypertonia in the right square. We have many techniques like the botulinum toxin injections, selective neurotomies, intrathecal baclofen, rhizotomies, and the orthopedic techniques. We can get this information. We had 2 published chapters in the literature about the spasticity and gait and the central and peripheral neurosurgical techniques for hypertonia. We can, in this book, Functional Neurosurgery and Neuromodulation, published by Professor Aslan and Kempershil. We can download the chapters and read every details. Based upon the best available evidence, standard care for children with cerebral palsy should include the green interventions. Both selective peripheral neurotomy and selective dorsal rhizotomy are effective on controlling spasticity, but in properly selected cases, results will be much better and long-standing. Combined rhizotomy may fill in the gap, part of the gap for cases with mixed form of hypertonia, and always multidisciplinary management is a must. Thank you for getting me in this conference, and we can join for questions, if any. Thank you.
Dr. Waleed. very much for this nice, interesting functional neurosurgical presentation. Now, question or comment from the audience, Dr. Abdul Ghani.
Any question?
Now, just to.
Thank you, Dr. Walid, for your comments. Thank you,
you.
Dr. Walid, for your nice lecture. Just I would like to ask you, are you using percutaneous radio frequency for dorsal rhizotomy? Percutaneous, without laminectomy. It's
yes.
minimally invasive.
Yes, we use a percutaneous radio frequency ablation for the dorsal root entry zone and the root at the exit foramina, but it is not selective and could be done for those cases with severe form of hypertonia with no ambulation or no sexual function, or just to relieve the tone and pain. So it's not selective. But those with motor function and residual motor function and ambulatory level, we should go for the full exposure and applying the neurophysiological techniques and monitoring to select these fibers affecting the hypertonia with reserving the motor and sexual and sphincter function.
Other question, the hypertonia is temporary or it lasting forever? Hypotonia after procedures?
No, it's it's temporary because it does not interrupt the motor fascicles, except in many in very selective cases and and few number of cases. So when we keep the motor fibers in the anterior root or the ventral root, we keep the motor function. Of course, we have some post-operative hypotonia from the manipulations of roots and cord, but actually it's improved within the few weeks or months after surgery with physical therapy.
Thank you very much.
Thank you.
Hello.
Hello.
I want to ask you, Dr. Abdul Ghani, in which cases you mix the peripheral neurotomy, for example, with orthopedic surgery? In which cases you mix the...
In which cases? Okay. When we find that there is a severe form of focal hypertonia affecting certain group of muscles, and those muscles are going to anatomical shortening, we have both elements of joint range of motion limitation with hypertonia and with shortening. So we control the hypertonia with neurotomy and control the length with functional orthopedic procedures. So we have long-lasting effect on the muscle length and joint range of motion later on. In severe cases, in presence of contractures.
Thank you.
Okay.
Any other question or any comment? Thanks.
Thank you very much.
Thank you, Dr. Walid.
Thank you very much.
Welcome.
I'm happy to share. Thank you. Goodbye.
Thanks. Now we will present Dr. Issam Al-Attar in his lecture of analysis of the morphometric changes in uncinate process of cervical spondylosis patients, a study of radiological anatomy.
Assalamu alaikum jami'an. My name is Issam Al-Attar, MD and PhD in spine surgery. My topic or my article today I will explain is about analysis of the morphometric change in the uncinate process of the cervical spondylosis patient, a study of radiological anatomy. It's already published in the Journal of Orthopedic Translation Journal last month, September, and the impact factor of this journal is 3.9. The purpose of the study, there are many research that focus on the relationship between the vertebral artery and uncinate process. There were no one concerning the difference in the dimension of the uncinate process between the normal spine and the degenerative spine. The other one of the purpose, there is anatomic parameters that can be used as a guide for the procedure in intervertebral foramen decompression and analysis of the morphometric change in the uncinate of the cervical spondylosis patient. I will give you a brief token about uncomfortable joint or uncinate process. It's also known as Loschka joint or joint of von Loschka. The guys who discovered this joint, his name is von Loschka. And or sometimes uncomfortable joint of von Loschka. It is only in cervical spine, only C3, C7, or sometimes to T2. Most prominent at C4, C5, C6. It made by uncinate process connecting with the facet for uncinate process. The shapes look like Batman Air. Here the photo of uncinate. Let your imagination how it is. Uncomfortable joint, it contains of two parts. The first part is uncinate process, also known sometimes ANCAS. As we say, is most prominent in C4, C5, C6. The second part is facet of uncinate process. It's really unnamed. It's article pad on the inferolateral parts of the same cervical vertebra. It's semi-trodatheradial because it has synovial lining and has some synovial fluid within it. This is anterior oblique view. And when we see the photo, the blue one is the uncinate process, and the blue line is anterovertebral foramen, and the yellow down there is the facet of the uncinate process. And this is other 3D photos. Let your imagination the relationship between the uncinate process and the vertebral artery and the nerve, the exiting nerve root. And we see there over there epidural venous plexus. Cervical neuroforamen is also known intervertebral foramen. It's created by the superior and inferior vertebral notch of adjacent vertebra. It transmit the spinal nerve as well as arteries and veins. The method of the study and material, there's a 40 patient from January 2016 until January 2019 were enrolled in this study. The material is three-dimensional CT of cervical spine were performed, and we divided it into two groups. The first group is non-degenerative cervical spine group. It contained 20 cases, male and female. The second group is degenerative cervical spine group, 20 cases, also male and female. There's 6 parameters concerning the height, width, and the angle of the uncinate were measured. The first parameter or first measurement is parameter A. It is the distance from the midline of cervical vertebral body to the medial pedicle cortex. The second parameter is B, is distance from the midline of cervical vertebra to the lateral pedicle cortex. Third one, parameter C, it is the vertical distance between upper border of the vertebral body and the minimum height of point of the uncinate process. Parameter D, the fourth one, it is the vertical distance between upper border of the vertebral body and the maximum height point of the uncinate process. Parameter E, fifth one, or number 5, it's the distance between the midline of vertebral body and the medial border of the uncinate process. The sixth one, or F, it is the distance between the midline of vertebral body and the lateral border of the uncinate process. Statistical analysis, its mean and standard deviation were calculated and compared for continuous variable parameters between non-degenerative group and degenerative group. It's independent, we use independent simple t-test and p-value. The result, it was less than 0.05, where it considered statistically significant. The result, we found in degenerative group, the average pedicle width was 3.63 mm to 5.91 mm from C3 to C7. And the average width safe uncinate resection will be as that's table from C3 to C7. The average safe depth and the second table, as we mentioned in the table. The result we got from the study, there are statistic difference between degenerative group and non-degenerative group, especially in those parameters. First one, minimum height of uncinate process and maximum height of uncinate process and medial border distance of uncinate process. Finally, lateral border distance of uncinate process. Here there's a curves for statistic and group 1 is red line, group 2 is blue line, and from C3 to C7 you see the curve is not there is differentiating. That's what gives us significant result. This is second one for curve for B value, and there is different cervical spine level. Mean it was statistically different between two groups. P value is less than 0.05. This is the table. It is from C3 to C7 as A to F and right and left, and compare between group 1 and 2. The discussion of the articles or the papers, the patient with cervical radiculopathy may have neural foramen because osteophyte accumulation or hypertrophy of the uncomfortable joint. If you see the two photos, the first one is nerve is relaxed, foramen is okay, and it's yellow. The other one, then it come narrow because the hypertrophy of joint or osteophyte, it become irritate the nerve root, exiting nerve root. This clinically important to uncinate process, provide lateral stability, and it make up the anterior and anterolateral border of the neuroforamen. As we say, when we get degenerative change, may it compress and irritate exiting nerve root, resulting in radiculopathy for the patient, and some is very rare, like vertebral artery, sometimes result in brain schema, but fairly rare. Symptoms of neuroforaminal stenosis include upper extremity pain, radicular pain, numbness, tingling, weakness. This I give you, for example, to show you how the nerve root it's like narrowing on other side. For this patient who suffer from neuroforaminal stenosis, we suggest uncinate resection performed with ACDF, anterior cervical discectomy and fusion, could achieve better outcome. Strength in our study, we are the first gagging the morphology of Chinese patient cervical uncomfortable joint and uncinate base in three-dimensional reconstruction CT. Second one, we compared to the study before. The researcher always use the CADAFA to measure the parameter of uncinate process and morphology. The data and conclusion may not as accurate as our study that we done in CT measurement of living person. Finally, we compared the anatomical changes between the uncinate process in normal cervical spine and that in the patient who suffer of cervical spondyloarthritic myelopathy. The conclusion of the study, in this retrospective study, our result suggests that the patient who suffer from cervical spondylosis could be performed intervertebral foraminotomy decompression by resecting part of uncinate process. Also, we provide the safe range with the spinal canal was up to 6.73 millimeter of width between inferior vertebral end plate and superior vertebral end plate in the intervertebral space. Also up 5.09 millimeter of depth from medial border of the uncinate process to the lateral side at C3 to C7. And the most important, we provide this measurement or the numbers is we resect the uncinate process without interfering the spinal nerve root and vertebral artery. The translation potential of this article, our study gives the safe margin to perform intervertebral decompression to the uncinate process cervical spondylosis patient. And this may help to improve the safeness of surgical provider. And the important one, it provides data for future robotic surgery. Here I give you photos, spine surgery now and spine surgery in the future. I hope my data or this study help to the future for robotic surgery. This is the reference. And thank you for your attention. Any question, please?
Thank you very much, Dr. Assam, for your presentation. Okay.
Hello.
Just one question, Doctor.
Yeah.
So when you have a case of cervical radiculopathy, and there is suspicion either disc or the narrowing of the exit of the nerve root, what you try or recommendation, what you will do for this patient? Yeah.
For which patient?
Patient with cervical radiculopathy.
Yeah.
You recommend to assess the compression of the nerve root, either CT or MRI?
Both. Both.
In every case you recommend both?
Actually, why we prefer to do CT, because there is some malformation in vertebral artery, and I saw before one cases there's malformation of vertebral artery. So we have to be in safe side. We have to do CT and MRI. The CT we can see the bone osteophyte or something. For after for the patient after he will relieve symptoms.
Also, every patient we recommend for both. It's so difficult for the patient.
Actually, maybe here the economic is not sufficient or is not good. Maybe sometimes we enough of MRI, but it's better to do both.
In China, you do that like that?
Yeah, we do both.
Thank you very much.
Yeah.
Okay. Dr. Abdul Ghani Nashr.
Thank you for your nice lecture. I'm agree with you with the CT scan with MRI combination. Let us to avoid a lot of problem.
Yeah.
A lot of osteophytes and a lot of degenerative change we cannot recognize by the MRI alone. Yeah. Especially in our country, that not all patients are doing good quality of MRI, which has 1.5 Tesla. But whatever, there is a lot of degenerative change we cannot see by the CT scan alone, by the MRI alone, or by the CT scan alone. So, Peter, I agree with you. Combination of CT scan and MRI, even if it is hard financial issue of patients, but it helps surgeon to do and to take a good decision. The other question, it is easy to do the compression of the foramen and release the hypertrophied uncinate process, it is easy because of bleeding.
Yeah,
Bleeding
yeah.
we are facing. Theoretically, yes, we see the picture, but in reality, you can do it civil and you can do it without any complication.
Yeah, it's a good question. A lot of surgeons, spine surgeons, they did ECDF only discectomy without resection of uncinate process, because when they go laterally, there is a bleeding, and sometimes they take care. They are afraid of they reach the vertebral artery, but it's not. As we mentioned in the PPT, there's a photo. Sometimes it's epidural venous plexus, and you try to stop bleeding and wait a while for minutes. Then you start to resect the uncinate process, go laterally. It's a little bit difficult. Yeah, I agree with you.
Okay. Any question? Another? Thank you very much, Dan.
Thank you for your nice presentation. Khaldi asked you in his first question what you are planning to do for the patient. Uncinate process, hypertrophy, or narrowing of the intervertebral foramen. Usually, it does not affect one foramen. It usually takes more than one level, and surgery has no rule in such cases. Do you think that physiotherapy or modulation of the life pattern can help the patient instead of facing the patient for a more sophisticated surgery for more than one level?
We go to the surgery choice after failed of non-surgical treatment. We start with non-surgical treatment, and we still waiting. If the patient not improve, we will go to the second choice, surgical choice.
Okay, thank you very much, Dr. Essam, for your nice lecture and informative. Now we present Dr. عدنان العواضي. أستاذ دكتور عدنان العواضي، استشاري جراحة المخ والأعصاب، رئيس قسم المخ والأعصاب في مستشفى الثورة العام. اتفضل في Okay, spinal hiatus cyst case presentation. Dr. Adnan.
Assalamu alaikum. Good morning, everyone. We have a simple case to discuss today. Is very rare and sophisticated cases, which is the hiatus cyst of the spine. This, equinococcus granulosus is a zoonotic infection that is a very rare in developed country, but is common in developing countries, especially in our country. And many species which can, many countries will be affected, like Mediterranean areas and South America, Middle East, Australia, New Zealand. In human, there is 50 to 77% of cases will be in the liver or in the lung, and only 5 to 10% will be distributed along the arterial system. From these 5 to 10%, only 0.5 to 3% will be in the spine. We will now discuss its life cycle. As you know, the definitive host is the dogs and some other meat-eating animals. The intermediate host is most commonly sheep, and humans are also incidentally intermediate host by eating the definitive host. The pathogenesis, by the 22nd day, it becomes visible by naked eye in the body, by naked eye, sorry. The host tissue response cover parasite by fibrosis. The parasite response to, we have three types of Echinococcus: the cystic Echinococcus or hydatid disease caused by Echinococcus granulosus, and the alveolar type and the Vogeli type. The hydatid of the spine is caused by Echinococcus granulosus, belong to the cystoid group, and the hydatid of the bone occurs in 0.3 to 3% of all the cases. The vertebral column is involved in 50% of these cases. And the other 50%, only the spinal canal is involved by compression and infiltration from the abdomen or from the chest. The pathogenesis, as we said before, the disease usually is spread by spread to the spine by direct extension from the pulmonary or the abdomen and fenestration to, and less often being primary vertebral body. The primary extradural hydatid disease without any systemic foci is extremely rare. It is a common cause of spinal cord compression in endemic area, and the diagnosis remain obscure until symptoms result from complication due to root and cord compression appear. The diagnosis merely made by history, endemic area, previous liver or lung disease, and also can be causatory or intradermal test, or by ELISA indirect immunoglobulin G test. Also by there is test give this test give a false positive result in cases of schistosomiasis or nematodes. Radiology is still the best diagnostic choice for hydatid disease in abdomen or in chest ultrasound. For spinal, for the spine, the CT scan and MRI is the best, better way to diagnose the disease. Our treatment is an anti-element or surgical excision or open surgical aspiration, injection, and reaspiration. The anti-element, we have two medication, albendazole and mebendazole, and there is another trial area for praziquantel in untreated cases of spinal hydatid disease. This is the most important solution that we use for an aspiration and reaspiration for the cystocyst killing inside the cyst. Now we start our case. Is a 35 years old male, single, presented to our department in July 2020, complaining of inability to walk and his lower limb inability to walk for 9 months. The condition started before 2 years as gradual increased back pain, progressive lower limb weakness. Soon he developed hesitancy of micturition, alternation of sensation of both lower limbs, which progressed to urinary incontinence, loss of sensation, and complete loss of lower limb movement. Past history, he has multiple surgeries for excision of multiple hydatid cysts of the liver and lung. The last one would be before 7 years. General physical examination, there is no abnormality neurologically. The neurological examination relieved the spastic paraplegia, complete paraplegia with SA grade A. Sensory level below the nipple, maybe at level 26, D6, D5, loss of sensation and pain, and fine touch. Superficial abdominal reflex was also absent, and there was hyperreflexia with hypertonia. Also, there was swelling in the back, which was extension from the chest hydatid cyst. This is the case first. You will see the multiple cyst was seen. This is the cyst with the bone destruction. Bone destruction, and the cysts go inside the spinal canal, made compression of the spinal cord. This is a multiple cyst was inside the right lung. This is another sagittal and coronal view of the chest, so the cyst and its involvement for the spinal canal. MRI view, as you see, the multiple chest cystic wall with septation and infiltration of the spine laterally, and also the great vessels and the mediastinum wall. A lot of cyst was seen inside the right lung and some part of the upper part of the liver. This is a axial section which showed the cyst okay, which may destruct the bone and go inside the canal and make a nerve spinal cord compression, which is a thin slide there. We planned for surgery with the assistant of thoracic surgeon and to be done in 2 stages. First, we will do the laminectomy and chest aspiration or excision. Then and the second step will be with assistant of general surgical or thoracic surgeon to access the remnant of the intrathoracic cyst. Patient was started albendazole for 100 milligram BD. Operation was done by decompression of the spinal cord and by laminectomy, cyst excision or cyst aspiration, and the injection of hypertonic saline. During operation, unfortunately, the cyst ruptured, but we thank that no allergic or anaphylactic shock happened to the patient. Multiple cells was evacuated by aspiration and re-injection of the hypertonic saline and aspiration again, suction of the content. We followed the cyst until the, sorry, but we don't have intraoperative picture. After the first operation, the patient started to move his lower limb with power grade 2+. Patient shifted to the surgical department on the 14th day, and the thoracic surgeon decided it's a non-operable case. Patient sent home for physiotherapy and albendazole for 25 days, 3 cycles with 14 days interval between each cycle. For a follow-up CT scan 2 months post-operative show a good decompression of the spinal canal with still there is remnant of cyst inside and the mediastinum. This is a photo of the patient with the 2 month follow-up. In September 2020, patient was able to move demented on a walker, power grade 3+ in both lower limb, but still incontinence for urine and stool. For our lecture at the end, what is the dose of the albendazole in short cases? We know that most hydatists will not respond to albendazole. It's only benefit in 30% of cases, and it's a short duration with its side effects, hematological depletion and liver toxicity. So, and also for what much time patients should take albendazole. There is difference in many studies how to take for 28 days or for 3 months, 6 months, or 1 year. And also, what is the prognosis of such cases? Can we, this operation is already treated the case, or it will have bad prognosis or good prognosis? What is the strategy for treatment in inoperable cases? We will answer this question. What is the dose of the albendazole? It was 400 milligram TD is the best dose for such cases with extensive hydrotosis. And the treatment is for 1 year, at least for 1 year or 6 months for such cases. I know there is a side effect of albendazole, but it's better to do a 14 days interval between each dose. The prognosis of these cases, there is a high risk of recurrence in 2 years with a 50% mortality, because excision of all the cysts in such cases is very difficult and dangerous for the patient. The strategy, we have two, LEM et al. Have 2 reported in inoperable cases of recurrent spinal hydrotosis treated with combination of albendazole and praziquantel have survived for 34 years. And this is the only study published for a long-living hydrotosis of the spine. This is hydrotosis of the spine is a very rare case, and there is only 2 series of retrospective studies discuss this issue. One of them is Mokondo et al. It's a 10-year series of 4 spinal cases, hydrated 3 men and 1 woman were diagnosed and treated at their institute, which with an average follow-up of 4 years. Hydrated disease of the spine is a rare condition with a poor prognosis, 50% mortality rate that presented diagnosis and therapeutic challenge. The second series was Primer et al. A 37 report of spinal hydrated disease published between the 1964 and 2000 were reviewed. nature of the disease, surgery alone is seldom curative. Adjuvant drug therapy as well as intraoperative prophylaxis are indicated. Despite all measures, the disease has a high propensity for recurrence and lead to progressive destruction of the vertebral column and neurological deterioration. Instrumentation with blood diffusion may be required to preserve the spinal stability despite aggressive treatment. Overall outcome is still poor, leading to prognosis measured by years. Thanks.
Thanks, Dr. Adnan, for this nice presentation of rare case in spinal hydatid cyst. My first question, what's the cause of this high rate of mortality in such cases?
The recurrence rate in 2 years follow-up for these cases, they find that the more 50% of the cases will develop another cyst, and also the cyst may be progress, and the complication of paraplegia or neurological deficit is mostly the cause of the high mortality rate.
Sequelae of
paraplegia or neurological deficit.
Thanks. Any question? Any comment? Dr. Majid?
Dr. Adnan, thank you very much. As long as you did surgery for such case, would you prefer to close the foramen and ablate the intervertebral nerve root? To ablate the root and close the foramen just to avoid recurrence? And as we saw, the lung is full of hydatid cysts, multiple small cysts. This is high liability to recur and to recompress the cord.
You mean that if I only do compression aspiration only? Huh? Yes. We do it, yes, but the cyst is very large and was extended to the chest, and there is a multiple extradural cyst, which was taken maybe done 4 to 5 levels, and also it was extended to the subcutaneous tissue, which was also ruptured during our first operation. So need we at that time we need also to evacuate the subcutaneous tissue, which was also invasive to the chest, and so the case become more difficult. Yes, we was aiming for only decompression the spinal cord, but during our operation we extended to the chest, the sac rupture, and it was a miserable case.
Multiple cysts inside the neural canal.
Yes, multiple extension. Yes.
Thank you.
More question, Dr. Khaled?
Thank you, Dr. Adnan, for this nice case presentation. I want to ask you, when you choose the surgery, you decide to start from the back, then from the chest. Why you can reverse? You can start from the thoracic area because of the source of the hydatid in the thoracic. Then you can shift to fix the back or the second.
Yes, we was planning that time is like you said, from the chest. Then we will do in posterior lateral decompression. Okay, we both with the surgical and thoracic surgeon, but our thoracic surgeon decided that we will go first, and he will do his operation late because he is not sure that the case is operable or non-operable, and he take another opinion of another surgeon, and it was delayed, and at the end it was not for their operation, and they decided it not for operation, an operable case.
He decided and escaped.
Thanks to God that we started first and decompressed the cord.
Okay, thank you. Because there is risk of rupture and anaphylactic shock, and he decided then escaped.
Okay, but for these cases, it's impossible to do total excision without rupture. It's a multicystic disease which was infiltrating so many areas, and the previous 7 operation with adhesion fibrosis, it makes this operation very difficult for simple excision and delivery of the case in such anywhere in the liver or lung.
And I think in the neurological status of patient makes the role of time compression of the cord itself is more important than the chest contents.
Yes.
Neurologically. Time is very important there more than chest. This is the main cause of starting laminectomy.
It's also a long duration, 9 months with paraplegia, urinary incontinence. Some we have a decision that not to operate because he will not improve his neurological function. But we find in our experience that the chronic or gradual cord compression will improve from operation, even if long duration, especially in hydatosis and in Watts disease.
TB.
Delay the surgery at the same stage.
Why we didn't do the operation at the same stage? It's the thoracic surgeon decision not to operate with us.
Dr. Adnan, good presentation for your case. A question for the stability of the spine.
We do interlaminar laminectomy, and the thoracic area is not problem for to do 3 to 4 levels interlaminar laminectomy without instrumentation.
Thank you very much.
Any more question? Any comment? Thank you. Now, thank you, Dr. Adnan. Shukran. Now, we will present Dr. Abdurrahman Dabwan from KSA. He's Yemeni, الطيور المهاجرة from Yemen, but working now in KSA, Kingdom of Saudi Arabia, to present his lecture, Evaluation of Failed Back Surgery Syndrome. Dr. Abdurrahman.
Good morning, everybody. How are you? Good morning, Chairman. You hear me?
Yeah. Start, please.
Good morning, everybody. Good morning, Chairman, Dr. Majid, Dr. Mujahid, Nasar, Dr. Khalid Sweden. In this morning, we hope you are in good situation. We are going to start to discuss an important topic. It's failed back surgery syndrome or failed back syndrome. Prepare our study in Al Kuwait Hospital, supervised by our Professor Dr. Majid Amir in 2010 about. This study was looked for, evaluated and reported the causes of failed back syndrome or how to avoid it and its risk factor. About the definition of the failed back surgery syndrome, it is a persistence of back symptom post back surgery, or in other words, it is a failed back surgery, failure of the back surgery to relieve the main complaint of the patient symptom regarding to his lower back or leg pain. About this photo, we see this simple anatomy of lumbar spine. We focus the failed back syndrome, our study, in the lumbar surgery syndrome, lumbar surgery. We see this picture, pedicle to pedicle decompression. In this photo, we see the green shadow of the area of decompression. The most important of this area is that.
Yes, excuse me. It's not showing correctly, the PowerPoint. Are you getting that, Mohammed, too? Are we seeing the presentation okay? I'm not seeing it very well. Are you guys seeing it okay?
No, still not okay.
It's okay?
No.
No, can you move the slide? It seems to be in the lower part of the screen. Can you raise it up? For some reason, it's low. Is it low for everybody? Is it low? Is it low for everybody? I need some help. I need some feedback. Is it low for everybody? Okay. Ahmed, is that presentation okay? It's not okay for me. Try it again. Try it again.
We will try to open the lecture from our side. Okay.
It's okay?
No, it's not okay yet.
No, it's not okay. Thank you for telling me. Okay. It's not okay. We've got to fix it. Okay. How can we do that? You see how it's low, right?
No.
We will open the lecture from our side.
Yeah, try it again. Try to share again. Because for some reason it's low. Try again.
No, this is the previous one.
Open your lecture from your side.
Okay, we'll open now.
Yeah, try it again.
We will open the lecture from our side.
Okay.
Okay, if you want to do it that way, that's fine. You want to try it again?
We will do screen share now.
Yeah, try it again. Yes, it's better. That's better.
Okay.
Yes, that's better.
Okay. We start now the failed back surgery syndrome, our study, and that's the evaluate and report the causes of the failed back surgery syndrome and its risk factor. In our study, we do our study in Al Kuwait Hospital in 2010 and 2011. We focus on the lumbar surgery, and the definition of the back failed back previous, the first, second, the previous one. Okay, the spine surgery basic. You can move the previous one. You heard me? Yes. The basic surgery of the spine surgery is basically accomplished only by two things. Number one is decompression of the nerve root and neural decompression from the pinch agent. Number two, stabilize the painful joint. So any patient complaining of back pain or same symptom or didn't improve from the back surgery, mostly he has no adequate decompression for the neural element or didn't stabilize a painful joint or micro instability issue. Next, please. Next. Yes. There is a predictability of pain after surgery. We can suspect the patient if it is relief from surgery from discectomy or, for example, if the patient become only leg pain, and he underwent lumbar surgery for this leg pain, mostly it is high successful operation in comparison to the other back surgery doing for the only lower back pain or fusion surgery. But actually, most patients will be improved for fusion. Next page. We do our study that this is the first paper in our study. We study the age group. We see that the peak incidence of our study is the 5th decade of life, about 41%, followed by the 6th decade of life, and decrease gradually. Next page, please. About the next column, we see the male predominance in our study, 55 in comparison to the female patient, about 34%. In the next column, we see the distribution of first symptom from previous operation. It was the both in our incidence. The peak was both leg pain and back pain, followed by back pain. The both patient complained leg pain and back pain was 72%. In the next page, distribution of the diagnosis in the first operation. We see that the most incident is the simple herniated disc, because there is a different entity. There is a lumbar disc and there is other entity different. It is lumbar degenerative disc. This cases we see the diagnosis in in the most incident is the herniated disc, followed by instability from the degenerative disease lumbar disc. In the next slide, we see the first operation which done for the operation in the bust. In the first operation, it was the laminectomy and discectomy about 65, followed by simple laminectomy 70, because most of the patients have degenerative canal stenosis and osteophyte in the facet. In the next slide, we see the improvement after the first operation. The improvement of the very first operation of the patient was good in about 65 and very good about 10% of the operation. And in the next slide, About the first onset of the pain post-operative, it was early, it was late after about 1 year, within 10 to 12 months, followed by early 37. The early feedback syndrome mostly belong to the cause of wrong level or inadequate neurodecompression in the intraoperative technique error. About the daily activity in the next slide, the daily activity, it is negative impact in the daily activity and doing work for the patient, which put the patient in critical situation to lose his job. About 55% of patients, it is affected his job. About the next slide, please. This is the distribution of first operation. Next slide. You hear me? Hello?
I'm not sure who's running the machine. Okay, next slide, please.
Next slide. Next slide.
Oh, maybe it's not functional. Are you trying to move the slide ahead? Whoever's using the screen share. Who is running the slide share? Maybe it's not working in the slide share. Okay, computer is not responding. Okay, I guess we're having, yeah, we'll just wait a little bit. We may be having a little glitch. Okay, Abdul? We'll just wait a minute. Apparently the computer's not responding. Just wait a minute.
Mr. John.
Yes.
Mr. John, we have problem in the laptop. We will restart now.
Okay.
Oh, okay. You can, okay, if you want to try to share from your side, Abdul, do you want to try that again? Because apparently the new screen share is not working. The new screen sharer is computers. Oh, we can just
see my slide?
Yeah, I see the slide, but it's according to the technician, it's his computer where he's sharing the slide from is not working. It's frozen. So, but usually if we wait a minute or two, it unfreezes. Ahmed, are you there? Okay, I guess the director is going to try a different procedure. Just hang in there. I think we're just hoping the computer revitalizes. Can you try it again, Abdul? Can you try screen sharing again? You want to try it again?
I share, but it's not
Yeah, let's see if
working.
it works on your side. Maybe it'll work on your side.
Now you see something from my side?
Yeah, it's still low. I don't know why, but I've never seen that. It's you see it, right? How low it is?
Yes, I see this my lecture in my telephone.
Yeah, see if you can move it. Is there any way you can move that up or how somehow?
I already moving now, moving the slide, but it's not appear with you. Unfortunately, I don't know.
Yeah, they can't raise it up, huh? Technical problem. So, okay, Mujahid, are you there? Or Ahmed, are you there?
Okay, LBC something to do.
Oh yeah, there we go. Yeah, there you go. There you go. If you can share that on your, that's a way.
Is this
Mother,
good?
yeah, that's fine. We're seeing it. That's fine.
Okay.
That's a good solution.
That's good solution. Okay, we see in this column the distribution of the first operation of the patient. We see that the big incident was in the laminectomy with discectomy, about 65%, because most of the patient was elderly and the fifth decade and have a degenerative canal stenosis, so underwent laminectomy and discectomy. Other big incident is 70% regarding to the laminectomy. In the other column, we see the distribution of the improvement. Most of the patients have good improvement, about 65%, but less percent have a very good improvement. In the distribution of the first onset of the symptom is the big inside 48% was the rate of some a couple of months, about 1 year the patient come again and complaining of the same symptom, followed by the early. The most of the early Feldbach syndrome mostly to the related to the inadequate neural decompression or long level. Regarding to the activity and daily activity of the patient, actually about 55% have a negative impact in his work. It is harmful to the patient, to the loose whole grip and extra. About the distribution of the causes of the analysis of our study, we see that the most incidence is 20% regarding to the instability of the spine, because most of the patient with degenerative cancer in the fifth degenerative lumbar disc disease and the fifth decade, post-operative has instability regarding to the micro instability or spondylolithiasis, followed by 70% regarding to the recurrent disc in the other level or long level. The wrong level here can be simply avoided by take a lateral view X-ray intraoperative. Better to do this to confirm the level of the disc intraoperative after the doctor do muscle dissection unilaterally before the start phlemotomy or laminotomy. He can take a shot of a screen before start and proceed his procedure of discectomy to confirm the level. About the diagnostic study, we do the 55% underwent CT scan. CT scan is to see the more bone detail anatomy and see the extension of the previous operation, or how they do the laminectomy or laminotomy or pharotomy, and the extension of bone removal is best to do to see by CT scan. The management of the patient with Feldbach syndrome in our study was 37 underwent a conservative and get improvement. About 62, most of the patient was underwent redo or surgical again. About the improvement after surgery, most of the patient improvement about 62%. What is recurrent or repeated surgery is very difficult from adhesion and scar and attached to the dura and high risk of CSF leak, and must be explained for the patient about CSF leak and nerve injury or something which is can be simply avoided by high technical surgical technique. In conclusion, in our study, we see that the prevention, the old word in the past, prevention is better than cure. So the doctor must be select and hyper select his patient and proper surgical planning and procedure, along with the history and detailed history and physical and radiological finding
دكتور
to do.
دكتور جون، دكتور عبد الرحمن اسمعنا؟
نعم.
يا دكتور عبد الرحمن.
نعم.
Yes.
نعم.
Now we will go to break.
دكتور عبد الرحمن
Thank you for your attendance.
احنا ما بنسمعش يا دكتور عبد الرحمن.
اسمع؟
ما بنسمعش ابدا. ايوه، والقاعه كلها يعني الان قد وقت البريك.
دكتور عبد الرحمن خلص المحاضره.
ما ادري كيف.
مسجله.
وكان الصدق نشين نسالك بعض الاسئله الصدق.
تسمعني طيب؟
دكتور عبد الرحمن قصدي يعني انترستنج كيتشر.
دكتور عبد الرحمن
خلص المحاضره تابعها.
احنا معك بس ما قدرناش نبثها لانه معنا مشاكل كذا شويه.
تمام.
استمر.
We conclude that the prevention is better than cure. The physician selection of the patient and proper surgical planning along with the history and examination and radiological finding is do a lot to prevent a negative consequence and economical and psychological impact in the patient. In the last slide, if the doctor didn't find clean and strong causes of the patient pain with radiological finding that and the radiological finding didn't match the clinical symptom of the patient, the surgeon must be avoid the surgery and pay attention to clarify the causes of the symptom. So review the clinical and history and the examination and the radiological facility as X-ray, CT, MRI to avoid the risk of failed back surgery syndrome. Thanks.
Thank you, Dr. Abdurrahman, for your informative and very nice lecture, and which we face too much in this type of surgery, which is failed back surgery. So, what is the, in conclusion, in your experience, how we decrease the percentage of failed back surgery? You hear me?
Yes, Dr. Khalid. You hear me now?
Yeah.
You hear me? Okay.
Yeah.
In conclusion, that the most proper selection of the patient and proper history along with the examination and radiological finding and more detail about the radiological finding, you see the X-ray, there is simple AP X-ray, there is oblique X-ray to see the bars, there is dynamic X-ray if there is instability of the patient. Also, we in the MRI finding anatomy, we must be to clarify the neural foramen and offending agent, and also to clarify that if there is canal stenosis, and we do proper surgical technique. For example, we must do a minimal invasive as we can. If the patient, for example, we only left leg pain, we do on the right side only. We didn't open all the interspinous ligament and remove the spinous process. We narrow our operation technique to the patient symptom, and we must be minimal invasive, and also must be respect and care about the bars. Don't disrupt and don't fracture the bars or the facet, because this is put a negative impact in the spinal instability in the future, in the short term or long term. So must be the preserve bars as you can, as we were. Otherwise, if your bars is fracture, must be put fusion in an option in the operation.
Okay, thank you so much, Dr. Abdurrahman. You know this who beside me?
لا.
دكتور سعيد بقى. دكتور سعيد.
حياك الله دكتور سعيد. Good morning.
ما يروح الا اصحاب العظام. دكتور Mr. Jun, you hear us? Thank you. We finished this session, and thank you very much.
Thank you.
For all. ليش؟ هكذا ليش؟ تصبحوا تتغدوا تاخذوا اسمه ادوا لكم هذا عبد الرحمن خلاص finished. Thank you very much.
يلا شكرا. Thank you for everybody.
See you later.
And sorry for technical error.
شكرا.
Thank you.
Yeah, okay, thank you very much.
Okay. Is anyone going to moderate? Dr. Mujahid, are you there? Or are we on break now? Oh, break. Oh, okay. We're on break. Okay. Hey, okay. We're on break now,
Yes.
huh?
Yes.
Oh, okay.
Break, Mr. John, yes.
Okay. Oh, okay. What, 15 minutes? 15 minutes? Okay. Very good.
30.
Hello, John.
Yes.
You hear me?
Yeah, can you hear me?
Yes, I hear you. We had a rest for 30 minutes. We come back after 19 minutes.
Okay.
We come back, okay?
Okay. Okay,
Did
I
you
wrote to
contact,
Goel.
did you
I wrote
contact
to
Professor?
Goel. I haven't heard from him yet.
I don't have his WhatsApp number. I only have his email. I sent him also an email,
Yeah,
but I don't
that's
have
how,
a response yet.
well, that's how I get
So
a hold of him. I email him.
you don't have a WhatsApp number for him?
No, I don't. Well, he speaks at 11:20
Mm-hmm. So,
Yemen time, correct?
let me see the schedule.
Is that
Yes.
correct?
8:20. Yes. 11:20 Yemen time. 8:20 GMT time.
Okay, so he speaks at 11:20 Yemen time, right?
Yes,
Okay.
that's correct.
He usually answers his email
So
pretty good.
we have 40 minutes
Oh,
until
okay.
his lecture.
Oh, he speaks in 14 minutes?
40.
Oh, 40. Okay. Okay. All right. I'll tell him that. 40 minutes.
Yes.
Okay.
So
From now.
we will try if he
Okay, let me
from
try.
now. Yes,
I'll
we will
write
try
it
to
right now.
extend the lectures and see. And Professor Lewis, he will have his lecture about 12:40. Yes.
Yeah. 4:30. Okay. Okay. I said you speak 40 minutes from now.
Yes. This Professor Atul. And Professor Lewis, maybe about 2 hours from now. Yes. Am I correct?
Well, he's 1:30. Let's see. He's
He will
1:30.
finish 1:30.
He's 1:30 Yemen
After
time, right? Let me see what time.
he will finish 1:30. He start after 2 hours from now. Dr. Lewis, Professor Lewis.
Okay.
Lewis Borba. He should start after 2 hours from now.
Okay. Are you getting in touch with him at all?
My phone now is not charging. He's still charging now.
Have you got he's pretty easy.
For that reason,
Yeah, he has WhatsApp. You get a hold of him?
yes, I told him yesterday. I confirmed him. He said yes. Now my phone is switch off. He is not charging.
Oh, okay.
But in 10 minutes, I will charge and I will contact him.
Yeah, he's at actually no, he's at 12:45 Yemen time.
Yes, after 2 hours from now.
Okay.
Am I correct? After 2 hours?
So it's 10:45 now in Yemen?
Yes. Yes, it's 10:45 now.
Okay, so it'll be 12. Okay, I'll tell Dr. Borba it's 2 hours from now.
Okay. Regarding Dr. Salim, I also contact him. We will introduce him from our side, okay?
Oh, you can introduce him, okay?
You hear me, John?
Yeah, please introduce him. I don't know him at all.
I don't know what you...
Well, look him up. Google him. I know that he works at the University of St. Louis. He works, you know as much as me about him. I know he has something to do with...
He sent us his bio. He sent us his bio, so we will do it. No problem. Okay, and thank you, John. You have a lot of patience with us.
Yeah, no, it's okay.
Thank you very much.
It's okay. Everybody's learning. This is new. And everyone will learn slowly.
Next time it will be much better. Yes, we're learning, but today I think it's better than yesterday. Yes.
Yeah, it's good. No, it's good.
Little bit better.
You're getting the information out. I mean, it's good information. So it's good to get out.
Yes. Very good. Yes.
Yeah, you have people in the auditorium there, huh? From the hospital?
Yes, we have an auditorium, about 300 people in the auditorium.
Oh, you're kidding. They're watching.
300.
You're kidding. In the auditorium, they're all
Yes,
watching.
they are
you?
watching.
Oh, good. People.
Now they are in rest. Nobody. But during lectures, we have at least 300 people in the auditorium.
Wow.
At least.
Yeah, it was the same when Ishmael was there a couple of years ago when we broadcasted.
It's almost the same.
Were you there?
Professor Ismail now he's not in Yemen. He's outside Yemen. Professor Ismail now he's outside of Yemen, not here.
Yeah, he's in Germany,
I
right?
contact him to present a lecture. Yes.
Yeah,
I tried to contact him to present a lecture, but he said he couldn't do it.
Yeah, he's in Germany.
It was a very nice conference last time.
Yeah, you were there. Were you there?
يا جماعة يا شباب الانترنت هذا unstable. Hear me? Hello?
Yeah,
Hello, John.
your sound is breaking up.
Yes, there is some internet problems. It's unstable.
Right
So
now?
maybe we will extend the break. Yes, maybe we will extend the break for a little bit longer if not connected. Okay.
Well, whatever you want to do.
الحين شغال عندكم الآن. هذا الحين نشوفكم انتم شغالين الآن. هذا بالواي ماكس ولا بالياكلك؟
افتح لي الصوت Mr. John?
Yes.
You hear me?
Yes, I hear you.
So John, maybe we will start the other internet line is not working properly, okay?
When you gonna start?
We should start in 11 minutes.
Okay. Is someone going to introduce the speaker? Is someone going to moderate?
But we will try to use the problem now is that the internet connection is slow.
Okay.
Slower than the previous one.
Okay. Well,
so we will try.
We'll try it. We'll try it.
Okay, that's good.
Okay, Dr. Goel's here.
Okay, Mr.
Yeah.
Hi, Dr. Goel.
Hi, John. Am I late or what?
No. You got plenty of time. You got about 40 minutes.
Yeah. So I was wondering whether I'm late.
No, no,
So
no, you're on time. This is Dr. Goel. Ahmed, this is Dr. Goel.
How are you, Professor Goel?
Yes, very good, very
Yes,
good, my
you don't
friend.
need to understand.
So
How are
I'm
you, Professor
looking
Goel?
forward. Just let me change properly. You are wearing a nice suit. Let me change. Let me just change and come
Yeah,
quickly.
we're
Okay.
on break now. Don't worry, we're on break.
Okay. Just give me a few minutes.
Okay, when does Dr. Goel go on in 40 minutes? 40 minutes?
Yes.
No, half an hour from now, half an hour.
Half an hour.
Okay. So I will be with you soon. Okay, John, don't get worried about me.
Okay. Well, I don't worry about you.
Okay. Okay, John. Okay.
Don't worry. John, you hear me? Hello, John.
Yes.
Do you hear me?
Yeah.
We should have Dr. Asim Abdul Latif with us now, but I don't see him in the Zoom, so I don't know if we can wait or if Professor Goel can start in 10 minutes.
Okay.
If he don't present.
Okay,
What
we'll
do you
just
think?
wait. We'll just wait. Yeah.
We wait 10 minutes. If
Okay.
Dr. Asim did not come, he's from Egypt.
And then you make
He's
a
from Egypt, not here.
okay. Make a decision in 10 minutes.
Yes. Okay, in 10 minutes. If Dr.
Yeah,
Asim didn't come, we will shift Dr. Goel to start.
Okay.
Earlier. Okay.
Okay.
Okay. See. Dr. Asim, you are here. لا انشاء يبدا محاولة موعدها. دكتور عاصم. دكتور عاصم here.
يا خالد.
John, Dr. Asim is here with us. Can you unmute him?
I don't know if he's here. Atul, are you here?
Yes, he's here. Dr. Asim, he's here. He's in the.
Well, his he may not
Can
be.
you
In
make
the
him a
room.
panelist?
I don't know if
No,
he's
here. He just sent an email.
من الآن معنا.
Atul, are you here?
Chat. He sent a. John, do you hear me?
Yeah.
Dr. Asim Abdul Latif, he's now with us in the Zoom. He sent a message from chat.
Okay.
Can you unmute him?
Okay. No, he's got to unmute
Can you
himself.
make him a panelist?
No, he unmutes himself.
Can you make him a panelist or no? Make him a panelist.
Oh, okay. Did he fall out? No, he was in. He was in.
No, he's now attended, not panelist. Make him a panelist. Can you make him a panelist? Yes, good.
Yeah, he was a panelist.
Okay.
Did he drop out?
Yes. Okay, now I think
he'll
he's
come back.
here.
He dropped out, but he'll come back.
How are you, Dr. Asim?
السلام عليكم. السلام عليكم. اهلا وسهلا. السلام عليكم دكتور محمد. السلام عليكم. كيف حالك؟ اخبار؟
ادينا بس دقيقتين ثلاثه بس انه بعد البريك انت عارف الناس بيحبوا ياكلوا.
تمام. ليك وحشه كثير يا دكتور محمد.
يا مرحبا. دكتور عاصم عبد اللطيف. ايوه.
حيقدموا جملة. انت تذكر اسمه ابو سعد وقول مع محاضره كذا وحيقدموا جمله بعدين يعملوا انترودكشن لازم.
هذا من والبقيه.
ايوه هذا ماكسيميليانو هذا من ايطاليا. نقدمه احنا.
طيب ايش صفتهم؟ نقدم احنا كيف؟
شمس الدين
يا عاصم نقدم حاجه معينه. لكتشر في السوريين عين شمس يونيفرستي ولا في حاجه؟
تمام مظبوط. تسلم.
وأقدموا جملة. ولا جملة واحد منهم.
ايوه انا شايف نسيج سنه.
John, can we start now?
Whenever you want.
Okay, we'll start now.
Okay, you got it. Who's the speaker? You got a speaker?
Yes.
Okay.
Yes.
Someone moderate. Someone moderate and introduce the speaker, please.
Okay.
Whenever you're ready, start to introduce the speaker. Okay.
Okay.
You're muted. You're muted. I can't
You're
hear
muted.
you. Okay.
دكتور محمد الصوت عندكم. انتوا muted.
So, Dr. Asim, you are listening now. Hear me?
That's good. Okay. Okay.
تمام.
Okay, please start.
Okay, go ahead.
Okay. Okay, so I'm gonna share my screen.
Okay. Introduce yourself, please.
Yes, sir.
ده هذا المصري عين شمس.
السلام عليكم ورحمة الله وبركاته.
Perfect.
Hello everybody. It's really a pleasure to be joining you in this meeting and this international panel of experts. I'm cutting myself out of the experts, but still it's a great honor to be with old friends as Dr. Mohammed Addashi. He's been a very dear and respectable colleague and friend. We've worked together a lot, and he even taught me a lot about endoscopy when I was starting my training in Egypt at Ain Shams University. So it's been an honor when he invited me to give just this humble presentation about how we can do endoscopy or manage with endoscopic third ventriculostomy in low and middle income countries. Again, my name is Asam Abdulatif, and I'm a lecturer of neurosurgery and pediatric neurosurgery at Ain Shams University. Received part of my training at Weill Cornell Medical College in New York with Dr. March Swedan, and this has been the boost to my endoscopic knowledge and the addition to my armamentarium in terms of intraventricular endoscopy. So without further ado, I'm going to be moving forward with the presentation. And this would, just a brief introduction. As we all know, we have a lot of literature and sort of publications talking about the hot topic in this area of endoscopic third ventriculostomy as
more, the sound is not well clear.
نعم.
Please make your mic is more clear.
More clear, yes. Okay. Is it clear now?
Yes, it's clear to me.
Okay. So I'm going to move forward. So we can see a lot of publications about endoscopic third ventriculostomy becoming a valid and durable treatment option for obstructive hydrocephalus. And this offers the advantages of the shunt independence with, this is a very interesting and inviting or motivating advantage to pursue endoscopic third ventriculostomy as a management of hydrocephalus. And with the past few decades, with the technological advancement, there was a sort of considerable minimization of the risk of the procedure associated with the procedure itself, the endoscopic procedure. Still, as the practice grows with every center, they face the challenges and the issues of the patient selection, the criteria, and the clinical and radiographic markers of success. And there is often sort of a controversy or debate about these issues. And therefore, literature would discuss the patient selection criteria, the prognosis, and the predictive factors. So no talk about endoscopic third ventriculostomy would not mention the landmark papers about ETV, and one of them is the benchmark of predictors of success, which is the endoscopic third ventriculostomy in the treatment of hydrocephalus. This was pioneered and championed by Abe Kulkarni and Jim Drake and his colleagues from London and from Tel Aviv. They devised this ETV success score, which is a score that has stood the test of time and was durable to act as a preoperative predictive model, and it helps with the parent and the patient counseling whenever we are, considering the endoscopic option for the treatment of hydrocephalus. They in this paper, they had a total of 618 patients with ETV done at their respective centers, and they randomly divided them into a training set to come up with the factors that predicted the success, which were namely the age, etiology, and the previous shunt, and then coming up through statistical methods with the weight for each factor, and then the validation set, which confirmed the durability or the predictive power of this model. But in the prediction, they found that the prediction was very strong, and there was sort of good adherence between the predictive power and the actual success in the patients with the moderate and with the high ETV success score. But with the low ETV success score range, there was sort of a deviation from the actual success. So this was basically because the patients, or there was a small number of patients in the lower score range, and they had a heterogeneous sample with possibly different techniques and equipment from different centers. Also, the cohort was collected over a lengthy period of time, some sort of technical changes in the technique itself that might cause the difference in the success in terms of intraoperative nuances. And they had sort of mixed prospective and retrospective data. So they had a follow-up publication in the following year, the same group, and they addressed this points of concerns in the previous publication, and they got an international cohort from 12 different centers, summing up 1,209 patients, an ETV cohort and the shunt cohort extracted from other previous trials, so this was still retrospective, and they stratified them again into the high, moderate, and the low ETV success score. With the Kaplan-Meier analysis, this was really a very interesting finding from them, that you can have a very durable ETV from the start with a success which is fairly higher than the shunt, and durability higher than the shunt, starting from the early post-operative period, and the difference is really marked after 2 years. With the moderate ETV success score range, the initial outcome is better for the shunt than for the ETV. Then at the age of 2 years, there is a switch, and the ETV success score, or the ETV, I'm sorry, becomes a more durable treatment option. And still, we can have, say, a similar outcome or similar follow-up with the low ETV success score, but with the differences in the magnitude of the discrepancy between the shunt and the ETV success. Other groups have managed to evaluate an intraoperative success for ETV or devise an intraoperative predictive model, and they were the group at Cornell, but this was early on, and they pointed out 3 scores mainly for intraoperative assessment with normal third ventricular anatomy, or the scarred or thickened subarachnoid space, and the presence or the absence of pulsations of the third ventricle at floor after the ETV. With the higher the score, the lower the success, and this is just the opposite of the ETV success score. So whenever we're undertaking an ETV strategy, there is something that we have to, or an ETV practice in the management of hydrocephalus, there is something we need to put in mind. And this was really a note by William Osler. This was his farewell speech to the Boston and the New York medical students. His advice was to begin early, to make a threefold category: clear cases, doubtful cases, and mistakes, and learn to play the game fair. No self-deception, no shrinking from the truth, and mercy and consideration for the other man, but none for yourself, and upon whom you should keep an incessant watch. And it's only by getting your cases grouped this way you can make any real progress in your education, and only this way you can gain wisdom with experience. So lessons learned from this is to categorize your patients into clear cases, doubtful cases, and mistakes. Get very objective and stringent assessment. Collect all the cases, no dropouts. Do reflections periodically and self-assessment. And this is how you can do some sort of the experiential learning activity. And this is why, because we are knowledge workers. We are high-performance knowledge workers who, as medical professionals, we just engage in non-routine problem-solving activity. And every day we face problems with patients and diagnostic thought process that we need to solve through a metacognition. The metacognition is something that we achieving through the identification of gaps in our knowledge or our experience through the objective self-assessment and the constructive reflection. And we should take necessary steps if we find any gaps or any defects to remedy the identified deficiencies. And this is the basis of the experiential learning, as I said, which is learning from experience. But the experiential learners are not knowledge consumers. They still produce knowledge through their generation of new insights while analyzing their own experience. And this will result in the transformation of experience from just a collection of data to synthesis of new hypotheses, theories, and workarounds to assess or to address deficiencies. So without the philosophy part, we adopted this idea or this concept at Ain Shams University at our center when we started to do the revive the ETV as a treatment modality for hydrocephalus, and we did a threefold ETV registry with expanding endoscopic practice from starting 2015 till 2020. And these are just, I mean, the cases that I started to collect after my fellowship training. And there we had the central hospital at Ain Shams University with 64 total endoscopic cases, and another procedures in satellites or 2 registries and other satellites at 46 and 19. We did sort of periodic self-assessment. So we started with getting the basic statistics after 24 months out of the registry with 42 cases of endoscopic procedures and 32 ETVs and 6 tumors with endoscopic management and complex hydrocephalus with septostomies and fenestrations. Most of them were having a subacute presentation, and the predominant radiological finding was aqueduct stenosis. The presentation was mainly divergent macrocephaly or delay in the milestones because they were in an predominantly infantile population. And our mean ETV success score was 60, and this falls in the moderate range. With a mean follow-up of, for those with meaningful follow-up, we had 28 patients, a follow-up of 7.6 months. Some things that we've identified as gaps in our experience or defects and deficiencies is the mortality, which was something remarkable, basically the operative causes. One of them died from neurogenic pulmonary edema and one from vascular injuries, and this was very early on from the first 10 cases we did as ETV there as independent practitioner. And we noticed a child with a void gain, but going to the prime objective, which is the success, we had a 61% success rate over the period of follow-up. 3 out of the failures had a redo ETV, and it was successful in 1, so we could collectively have a final 64.4% success for the ETV, and the mean failure time was within the first 3 months. We defined success as longevity of the ETV without the need for another form of CSF diversion in the absence of any clinical manifestations of hydrocephalus. Then we repeated this assessment 35 months after out in the registry, adding more patients in each category, and the aqueduct stenosis was still standing as the most common radiological diagnosis, with still the mean ETV success score falling in the moderate range and having a 60% or the total final 62% success rate, and still getting in the range of 2.6 to 3 months. And this was repeated, I'm sorry. So we had some comparable results to the international figures, but we felt more can be done because mainly we had concerns of the high operative mortality, which deserves definitely attention, and revisiting the procedure, whether technicality and the indication, and what really defines the scar pre-pontine interval, dense adhesions. How can we just quantify this? Because still this is subjective, or sometimes it's intersubjective. What if the membranes in the pre-pontine cistern were pulsating, but not the flow of the third ventricle? This count in the intraoperative assessment or the score. So these were still things that maybe a growing registry or addition of data would help us discern. Another landmark paper is the paper that came up about 2 years ago. It's the results, the 5-year follow-up of the International Infant and Hydrocephalus Study, because this is something that really concerns pediatric neurosurgeons and parents, is that patients who undergo ETV, sometimes oftentimes they don't experience this ventricular drainage and ventricular drop down in the volume as compared to the shunted individuals or the shunted children. And this may raise the issue of the cognitive assessment and the developmental delay possibly. But in there, the group at this international cohort study, they were intending to answer this, having more infants and children younger than 24 months with symptomatic triventricular hydrocephalus, mainly aqueduct stenosis, and they presented their 5-year outcomes in terms of the the HUI score, which is the health of developmental score, and I'm not sure and the HOQ in an overall score as well, but they found all scores for the development and the cognitive assessment for the children were similar, and there were no significant differences between the 5-year scores, subscores with the cognitive, social, and physical and developmental measures between the two groups. So they coined this as the first prospective direct comparison of long-term outcomes of ETV and shunt for infantile hydrocephalus, and they suggest that the overall health status and the quality of life of this cohort of infants in aqueduct stenosis is very comparable between the ETV and the shunts. But the pattern of hydrocephalus in the developing countries is really somehow different. And we're also having a parallel hydrocephalus registry or pediatric hydrocephalus registry going also synchronous with the ETV registry, and this has pointed out that we have different patient population. Data from the developing countries project an increasing time trends in the occurrence of congenital hydrocephalus, but still what's really prevalent and reported by Benjamin Worf in East African countries that still infantile hydrocephalus due to high birth rates and high incidence of hydrocephalus secondary to neonatal infections is on the rise. And we can find that the Chiari type 2 associated or the spina bifida associated hydrocephalus and the post-infectious hydrocephalus are amounting for more than 50% of the patients that we're dealing with at our institutions at Egypt, being a low middle income country. And the previously available treatment for these children was the placement of ventricular peritoneal shunt, but there is a financial burden of purchasing the shunt, either on the healthcare cost or directly from the patients if they're paying out of pocket. And more importantly, in shunt-dependent patients, there's some sort of an increasing risk, as this is popularized or advocated by Benjamin Worf and his colleagues, that the longer the shunt in place, the risk, the added risk or the cumulative risk over the years would be substantial, and that sometimes they may have obstructed shunt with acute hydrocephalus and they're in a distant place with limited access to healthcare, to an appropriate healthcare facility, and this may result in grave complications for the patient. So what if something more could be done to improve the outcome, especially in this post-infectious hydro and the spina bifida associated, or the children younger than 1 year? And we are aware that they would have a preoperative prediction according to the ETV success score of less than 50. So, as I said, the champions of the technique, Benjamin Worf and his colleagues in Uganda, and then he also extrapolated this to centers in North America. He combined endoscopic third ventriculostomy or the ETV with choroid plexus cauterization, and there was a rationale for this because it improves the compliance, decreases, acts as a pulse absorber, and also decreases the amount of the CSF that's facing or challenging the subarachnoid space for absorption. But anyway, when he just compared his or analyzed his patients, he found an overall success rate of a combined ETV CPC was 66%, and this was superior to the original 47% in infants younger than 1 year with ETV only. And the increase was mainly robust, or the improvement in the outcome was mainly robust in the spina bifida associated population and not in the post-infectious patients. And then he analyzed another group of patients with myelomeningocele, focusing on them, and he found a 76% success rate with a mean follow-up of 19 months. And most of the treatment failures, which was really he pointed out and stressed upon very frequently, is that most of the treatment failures, or 86% of them, they occurred within the first 6 months and none of them after 10 months. And he coined this as a safe period because of the soft pliable skull, still the retained brain compliance. So manifestations of an obstructed ETV would be noticeable by the parent, and through a divergent macro or a bulging tense anterior fontanelle or irritable kid, and still the urgency of getting a revision of the ETV or putting in a shunt is not as urgent as it is when dealing with a child who is older than 2 years with more rigid skull and acutely increasing intracranial pressure. Then advocates followed who trained in Uganda for a few months or a few years, and then went back to the North American centers that they belonged to originally, and also advocated the technique there in Miami Children's and also in Alabama. They're having big centers, but also in other centers in Africa. They started with Nigeria. So we were also getting a sort of excitement with the technique, and we started our preliminary experience with ETV CPC with an ETV success score preoperatively of 50, and we used a rigid scope, not the flexible scope, and we did bilateral CPC in the lateral visible parts of the choroid plexus and the lateral ventricles with complete cauterization of the visualized choroid plexus. These were at first lengthy procedures lasting for more than 60 minutes, more irrigation fluid, and this may pose idea of the hypothalamus being exposed to irrigation fluid for a long time. We had 2 deaths from acute neurogenic pulmonary edema in the early postoperative period. 2 patients were successful, and 2 patients eventually had ultimately ended up ultimately placing a shunt to around 3.5 months. So this is a very discouraging results for us. So we needed to have more attention to the indication, the technical pitfalls and equipment, and the only way to learn this is to go to where it was devised and designed at first, and start with the mindset of implementation of the Cure Hospital experience. So we need to go to the Center for Collaboration, establish a partner treatment location, and at our center, and receive formal training, which helps with the diagnostic thought process, the decision making, the protocol implementation, and technical training as well. So we started by sending one of our colleagues or the young residents who have recently graduated from our neurosurgical program to Ben Worf for his training at Boston, and then planning to establish sort of satellite to the Cure Hospital experience in Egypt. We're working on this in the meantime, but other centers have succeeded us in this, as Nigeria and Zambia and others. And comparing the Nigerian experience to the original Cure Hospital experience, we can find that they had comparable results. Admittedly, the early treatment failure of ETV was higher in Nigeria at first. At the first time they adopted the technique, they had a 54% failure rate compared to the 28% failure rate of the Cure Hospital. But the overall shunt freedom at 6 months was really very comparable. And considering that this is a lower volume institute and they're still not as experienced as the original center in Cure Hospital, they have these are very encouraging results, and possibly the explanation for the difference in the early endoscopic outcome possibly could be the surgical technique differences in the decision making, also regarding the patient selection or the intraoperative conversion from ETV to ventricular peritoneal shunt, how to judge an Yes, I just have 1 minute and we'll be finishing. Failure of the ETV and undergo an ETV revision, all these were possibly explanations. And some of the things that we need to put in mind is that the Cure Hospital have devised their own ETV success score, or the predictive model, and it was based on age, etiology, and choroid plexus cauterization. They put a lot of weight on the choroid plexus. And what's the added benefit for this is the less shunt-dependent children with subsequently less cost of hardware, less incidence of late and sometimes life-threatening complications, and it just became a more durable treatment. And also they analyzed their patients and found that there was a similar volumetric analysis and similar cognitive outcome between the shunted patients and also the patients who undergone ETV and CPC. So this is the Cure protocol it still has ETV in it or alone, but whenever there is sort of an aqueduct which is closed and a cistern which is a little bit not that scarred, so they would proceed with an ETV CPC whenever there is a higher likelihood of failure of an ETV alone. And also dealing with a failed ETV, they can also add either do a VP shunt if there is cisternal scarring originally and this was mistaken or overlooked, or do another repeat ventriculoscopy to assess the ETV, or add the CPC whenever it was not added. So I'm really thankful for your time, and I'm open for any questions. Thank you.
Very good. Go ahead. Go ahead.
So, Dr. Jones, shall we continue with other speakers?
Yes, I'd like to introduce Dr. Goel. Are we ready for Dr. Goel now?
Yes, please. If we just open the floor for 5-minute discussions, could be, or
okay, sure,
time is going.
Sure, okay. Okay, the floor is open for questions or comments.
That's okay. From the audience, any questions, any comments? So, Dr. Jones, since there is no comments or any questions, should we continue to the next speaker, please?
Yes, of course. It does me great honor to introduce a friend, Dr. Atul Goel. I first met him online when he was doing a presentation for Ipcherian. And Dr. Goel, I didn't know who Dr. Goel was. I'm not a neurosurgeon, but I saw him spend a lot of time with just 2 residents on the webcast. So he's dedicated to teaching. It's good to see you, Atul. I'm glad you came.
Thank you, John. Can you wait?
It looks good. Looks good.
You can hear me, John?
Yes, it looks. Yes, good.
Okay, so should I begin?
Sure.
Okay, my dear friends from Yemen and from other countries, it is my great pleasure and big honor to present you my work on complex brain tumors. Complex is in the word complex is in the mind. Difficult is in the mind. How we make this complex, make this difficult easy. How we make it simple. How we understand that. How we understand the brain tumors. How are our techniques. How we demolish the tumor is very important and a learning of life. We learn this all the time, and that is the beauty of our great subject of neurosurgery. Without any question, it is critical and important to know the anatomy of skull base, anatomy of internal carotid artery in the cavernous sinus, anatomy of the cranial nerves, anatomy of various structures located in the skull base. Without anatomy, there is no surgery. One is published in 1996 and one is published in the year 2011. This book is 1996, means 24 years ago this was published, and the whole book is a biographic. It is a monographic book. All the techniques in this book are my personal techniques, and some of these techniques which I am going to show you are from those days. And I will show you one important slide, and you will be very happy to see this slide. Alam al-Dimag. This is from Arabic literature, Arabic mythological literature, where it is said that meninges are the mother of brain. Dura mater means dura mother. So this dura mother is a word taken from Arabic legacy. And dura is absolutely a fantastic material, like a cloth, very solid material. Dura is durable. You see, this dura covers the brain. and there is no hole or gap in the dura. There is no hole. No bacteria or infection can enter. No, you see, no corona can enter into the brain because of this dura. The paranasal sinuses, which are just below the skull base, external ear canal, which is just below the skull base, are loaded with animal biomass. But no bacteria can enter into the brain. No virus can enter into the brain. This is a sterile cavity. This is a divine cavity. So this dura is an absolutely marvelous creation of the Mother Nature. On the basis of dura, my concept is that the tumors respect the dura. And on that concept, a number of my technical articles are based, and many of those technical articles I am going to discuss with you on the basis of my almost 30 years of experience in the subject of cavernous sinus and in the subject of skull base. Meningeal architecture or the dural architecture of cavernous sinus is an absolutely critical in understanding of surgery of cavernous sinus. Internal carotid artery. You see, 22 years ago, I wrote this article, Impact of Arterial Displacement on Strategy for Cavernous Sinus Tumor. This artery is encased by the tumor and compressed. This artery is encased but not compressed. This artery is displaced by the tumor. So these pictures are from this article where I have said that on the nature of encasement and on the nature of displacement of carotid artery, you can identify the pathological nature of the tumor. You can say this is pituitary tumor. You can say this is meningioma. You can say this is nasopharyngeal angiofibroma on the basis of the arterial displacement as the tumor will cause or encasement. In the year 1997, we described extradural approach to lesions involving cavernous sinus. We all know Vinko Dolenz described vascular lesions, how to approach these vascular lesions like aneurysms extradurally in the year 1985-84. And he also described extradural approach to some tumors in the lateral wall of cavernous sinus. But extradural approach to intracavernous sinus tumors was first described in this article. So this is one tumor which is entirely intracavernous. This is cavernous hemangioma of cavernous sinus. This tumor respects the dura. It does not transgress the dura. This is the lateral dural wall of cavernous sinus. The tumor goes into the intercavernous sinus like this. Does not go outside the dural confines of the cavernous sinus, encases the internal carotid artery, and this is one of the most benign tumors of the difficult neurosurgical problems, cavernous hemangioma of cavernous sinus. Characteristic radiology. So if you know that these are hemangiomas, you cannot come from the nose because the bleeding will be just too much. So this we first described in 1991. This was the preoperative and postoperative image. No matter how big this tumor becomes, the dura mother is respected. The dura is not transgressed. The tumor goes till the orbit, till the Meckel's cave, intercavernous sinus, encases the internal carotid artery. It is angiographically occult, does not show the vascularity despite the huge vascularity. And this is the postoperative image. If you remove, you give new life. Removal is difficult. It is complex. Extradural approach. Cavernous sinus is an extradural entity. For the first time in the literature, we described that cavernous hemangiomas can be removed extradurally. And now all the people, most of the people who do cavernous hemangiomas approach these tumors extradurally. First thing you have to expose is the sixth nerve, and then isolate the carotid artery and then remove these tumors. So extradural, because the tumor respects the dura, The tumor is located in an extradural space. So this is the patient who came with extraocular movement disturbance, third nerve disturbance, sixth nerve disturbance. There is no radiation that can work. The tumor goes out, the dura is displaced. Tumor goes in the intercavernous sinus. Carotid artery is encased by the tumor. This is post-operative scan. Let me show you a little bit of video of this patient. So this is extradural approach. When you are doing, you see, this is the right temporal. First thing that is to be done is to cut the middle meningeal artery. Then you will be able to dissect and elevate the dura of the cavernous sinus. You see here the cavernous sinus. This tumor is going to bleed. What we have to remember is we have to work within bleeding territory. You cannot have a clean field. You cannot have bloodless field. You cannot have a white field. It has to be red field. And then you have to go on dissecting, expose the cavernous sinus extradurally. The cranial nerves of the lateral wall. These are the 5th cranial nerves which are displaced outside the lateral wall of cavernous sinus. Little bit bloody, but don't worry. You have to go on and resect the tumor. You see, this is the, now you will see, just see the little bit of, enjoy the blood for some time. And then I try to approach the tumor between V2 and V1. Then I come between, above the V1, you see, I'm trying to get little bit, not, you see, this is almost completely unedited video. I'm going fast from here with my cursor, but this is an unedited. First thing that you do is to identify and save the 6th nerve. You see here, the 6th nerve I can see inside the cavernous sinus. You see the 6th nerve? You identify the 6th nerve, and then you remove this tumor. If you are able to remove this tumor, this is the carotid artery inside the cavernous sinus. And this is the image after the tumor has been removed. Most important is eye movements have returned, the ptosis, and this is 3 months after surgery. The ptosis has gone, eye movements have returned, and the smile has also come. You see the depressed face, you see the smiling face. And this is another case I'll briefly show you. This is the cavernous hemangioma of cavernous sinus. I am adopting a transgasserian ganglion approach. You see, I have opened the tumor extradurally. I'm opening the gasserian ganglion and then going inside the cavernous sinus. You will see I have split the gasserian ganglion. These are difficult tumors, but it may bleed, and it may bleed very furiously. To get hold of the bleeding, we have to get hold of the, you see, this is the tumor I'm removing, and then this is a vascular tumor, but if you remove, you are able to give new life. Now the question is whether you are able to remove or not. If you understand the dura of the tumor, you understand the tumor, you understand where the cranial nerves are, you know the anatomy of the tumor, anatomy of the region, you can certainly, without any question, you can remove this benign tumor and give new life. On the other hand, you must understand whether you can do it or not do it will depend. This is the internal carotid artery inside the cavernous sinus. This is the tumor has been resected, and then I will control this bleeding with packing of Surgicel. So this is preoperative and this is postoperative. This is huge cavernous hemangioma of cavernous sinus with a flow-related aneurysm. Even if it is huge, the dura is preserved here. Intercavernous sinus extension, work within the dura, extradural approach, you can remove this tumor and you can clip the aneurysm. I had described this some 20 years ago. Now I will show you the beauty of dura in trigeminal neurinoma surgery. This was my article in 2003 when I published the largest series at that time. Now my series is about 300 cases, which is also the largest series. We described for the first time that trigeminal neuronoma arise from the Meckel's cave in the region of Gasserian ganglion. We also said that these tumors remain within the lateral wall dura, or they are interdural in location. Even the posterior cranial fossa can be within the dura. This is what we described. So working interdural, you can remove these tumors, and that is the beauty. So we also described that you remove the tumor, you can save the function of fifth nerve. So this kind of description was never before this article was described. Not only save, you can improve the facial sensation. So that is the article where interdural approach was described. So you see in 1995, my hands are like this, just widening the Meckel's cave, open the dura of the Meckel's cave, work interdural. So my technique was infratemporal fossa, interdural approach. So we did not do even craniotomy. 25 years ago, you must remember that these tumors were difficult to operate. Even now they are difficult. This tumor in the lateral wall of cavernous sinus, you can diagnose on the basis of clinical finding, open the dura, and you can remove it beautifully interdurals. We also removed the tumor behind, going in the posterior fossa and in the lateral wall of cavernous sinus by just widening the foramen ovale without any craniotomy. This was another case in my paper which we published in 1994, no craniotomy. So the beauty is that trigeminal neuronoma respect the mother dura. During surgery, if we respect the mother dura, we know how to break the tumor, demolish the tumor, and save the fifth cranial nerve. We can give absolutely beautiful sensations to the face. These kind of large tumors are dangerous and difficult, but if you know the anatomy of the tumor and of the region, working within the tumor, working within the dura, demolishing the tumor, no heavy coagulation, we must know that the carotid artery is displaced by the dura. Cavernous sinus venous plexuses are displaced. No need for coagulation within the dura. Break the tumor, and you will remove and beautifully remove. In 1991, about 30 years ago, these kind of tumors were removed in 2 stages. Then Malice described removal after pictosectomy in 1 stage. Of course, in 1991, this was my tumor. I removed in 2 stages. This was another tumor I removed in 1992. First, I removed the posterior fossa, then the middle fossa in 2 stages. But as we understood our anatomy, and we now do in 1996, I described this basal subtemporal approach, subtemporal craniotomy, doing mastodectomy, removal of roof of external ear canal, removal of roof of condyle, removal of root of zygoma. So this was the craniotomy we had described in 1996. I do not use all these things now, but for large tumors, basal subtemporal approach is good. Now we just split the temporalis muscle or split the temporalis muscle like this and do a small craniotomy in the lateral squammal temporal bone. We can even elevate the temporalis muscle like this and do a basal subtemporal craniotomy. So for these large tumors, I do a very small suprazygomatic craniotomy, splitting the temporalis muscle, working within the dura, break into the tumor, demolish the tumor without coagulation, and you can remove these tumors within 20 minutes or half an hour, and there is no excessive statement that I am making. Many of these tumors work within the dura. Dura is present even here. Dura is present interdural, and you can remove the tumor in very beautiful way. So this is preoperative, postoperative. And as I mentioned, we have the largest series in the world, nearing 300 cases. You see this small nubbin in the middle fossa. This is not joining or going towards the carotid artery. There is dura protection, there is mother protection. Work within the tumor and demolish the tumor, and you can have a beautiful resection. Which are going extracranially are also interdural in location, and we can do reverse transcranial, reverse skull base approach to resect these tumors in a very beautiful manner. Preserve the mother dura. That is the beauty. This is C2 ganglion, very similar to Gasserian ganglion. Gasserian ganglion is the largest ganglion in the brain. C2 ganglion is the largest ganglion in the spine. Trigeminal ganglion is located in proximity to the carotid artery. C2 is proximity to vertebral artery. Trigeminal ganglion is located proximity to cavernous sinus. C2 ganglion is located in a venous complex here. C2 neurinomas also arise in the same fashion. They arise outside the spine. All other ganglions are inside the spine. Only C2 ganglion is outside the spinal canal. C2 ganglion arise inside the dura. You see, C2 ganglion also has intraspinal, interdural, interdural, intracranial, interdural, like trigeminal neuronoma. So working within the dura, you can remove these tumors in very beautiful time. In 2008, we described C2 neuronomas in this fashion. But in 2008, we described that even this part of the tumor, even the spinal part of the tumor is interdural in location. Work within the dura, and you can remove these tumors in 15 minutes or 20 minutes. Do not coagulate. There is no need to have proximal control of vertebral artery because it is outside the dura. So that is very important. This is C2 neuronoma. These tumors I removed without doing any bone work. This is trigeminal neuronoma I did for the first time in the literature without any craniotomy. So this is C2 neuronoma, very similar to trigeminal neuronoma. Now I show you third nerve neuronoma. This is a tumor which looks very complex and dangerous tumor, but this is a third nerve neuronoma, and this is also interdural in location within the confines of the dura. So to have anatomy is absolutely important when we are going to operate these patients. So interdural location of oculomotor neuron. When the oculomotor nerve goes here, it arises from the oculomotor cistern, the tumor. The tumor arises in this cistern, and as it grows, it dilates the cistern. And this complete dural, these tumors remain within the dura. And you have to work within the tumor without this tumor capsule is not capsule, it is normal dura. And that we have to know, and you can preserve the eye movements. That is very important. Third nerve, nobody in the world has ever described improvement in third nerve function. So this is third nerve tumor. There is dura around the tumor, and you can work within the dura to remove this tumor. This is sixth nerve tumor. Sixth nerve is inside the cavernous sinus, and this is the only tumor which can encase the sixth cranial nerve. Now I'll show you seventh nerve tumor. You see, this is the seventh nerve tumor. It is also interdural in location. It arises from the geniculate ganglion and remains within the confines of the dura. Even the posterior cranial fossa, middle cranial fossa, you come from lateral, open the dura, work within the dura. Dura will protect you from carotid artery, and you can remove this tumor in very good time. Another beautiful thing I'll show you is interdural approach to lower cranial nerve neuronoma. This is lower cranial nerve. They also remain within the dura. You work within the dura, avoid transgressing the dura and transgressing the dura, and you can save the lower cranial nerve function in a beautiful manner. So this, whether it is going extracranial, this dural boundary protects the tumor, and surgeon, it protects the other lower cranial nerves. Now I want to show you the magic of dura in pituitary tumors on the basis of my several publications on the subject. And I wish you can read some of these publications. So these large pituitary tumors can be dangerous and difficult to remove. But you must remember these large tumors also have a very defined anatomical situation. Grade 1 tumor is, as the tumor grows, the diaphragm, the dura of the diaphragm is elevated by the tumor. This concept that the dura of the diaphragm is elevated by the tumor has completely revolutionized pituitary tumor surgery. So this concept we introduced in 20 years ago. Before that, all these tumors, these large tumors were removed transcranially. So when the tumor grows, the diaphragm grows along the tumor. So the whole tumor is subdiaphragmatic. You come from here, break the tumor, and you can get removal of these tumors. This nubbin is also a dural nubbin. It is not transgressing the dura. It is not dural nubbin. The dura remains intact. Mother dura remains in the brainstem but remains intact. Grade 2 is when it goes in the cavernous sinus, in cases the carotid artery dura mother remains intact. So in both cavernous sinus, these are grade 2 tumors. Diaphragm remains intact, dura remains intact. So diaphragm, dura. This anatomy is very important to understand. Diaphragm stretched lateral. The roof of cavernous sinus. This is dura of diaphragm, dura. So the whole thing is within the dura. So there is dural cover over the elevation of roof of cavernous sinus. This concept was also introduced by us first in the literature. So this is dura of the diaphragm, dura of the roof of cavernous sinus. The whole thing is under the dura. You see clearly the elevation of dural roof of cavernous sinus. Beautiful elevation of dural roof. John, there is some disturbance. John? Okay, so you carefully see this slide. There is elevation of diaphragm celli and elevation of dural roof of cavernous sinus. So this anatomy is very important. So an elevation of dura, elevation of diaphragm, elevation of roof of cavernous sinus. Grade 4 tumors are when it encases the arteries of circle of Willis. These tumors become aggressive, and these are very less common, and the surgical principles are different. So my grading system is grade 1 when the diaphragm is elevated. Grade 2 is when the tumor goes inside the cavernous sinus. Grade 3 is when the roof of cavernous sinus is elevated. Grade 4 is when the artery of circle of Willis is encased by the tumor. So my basic thing that we revolutionize pituitary surgery is by the concept that the diaphragm is elevated by the tumor. The tumor remains in the cavernous sinus under the dural confines. So these are very fantastic understanding for this subject. So this is large pituitary tumor. Just open the anterior wall, demolish the tumor. No need to coagulate, demolish, and the whole diaphragm will come into picture in no time. So these large tumors can be removed in 20 minutes or 15 minutes, and you can have a wonderful post-operative outcome. 1997, I removed this tumor. So the concept is that uterus will push the baby down. And similar concept is that the diaphragm will push the tumor down. Break into the tumor, and diaphragm celli will come into picture. Break into the tumor, and you will have wonderful clinical outcome. So there is some disturbance, my dear John. Hello.
Yes, I got it.
There is some disturbance, John.
Yep, we got it.
Okay, so when the tumor goes in the subfrontal like this, even the dura is covering the tumor. And we must remember that these are very beautiful cases for transnasal operation. No need for transcranial surgery. Even when the tumor goes like this, the dura is preserved, and you can remove. There is no need for transcranial surgery. Learn the art of breaking the tumor. Learn the art of demolishing the tumor. You see, in 2001, 20 years ago, I removed this tumor, demolished the tumor, and you can have beautiful. This is another tumor I removed 21 years ago by transnasal route, by understanding the fact that the dura is going to push the tumor back. Removal of part of the tumor in the cavernous sinus is a difficult and prolonged subject, but whenever it is required, you have to remove the tumor which goes in the cavernous sinus and elevates the roof. This understanding of the dura will be very, very critical during those times. So elevation of the roof. So if you know that the dura is going to be intact, you can come and remove this tumor in the cavernous sinus. When the arteries are encased, this becomes an aggressive tumor because the tumor is not respecting the dura. Mother has to be respected. Those who do not respect the mother are a little bit aggressive children. So this is aggressive tumor, and aggressive form of treatment is necessary. I now want to show you quickly chordomas. Chordomas destroy the bone but displace the soft tissue. They remain extradural. They displace the cavernous sinus on the dome of the tumor, and they displace the internal carotid artery entirely. So there is anterior displacement of carotid artery. Dura is intact here. If you have this understanding of anatomy that the cavernous sinus nerves are going to be superior, you can remove these tumors beautifully. So we describe this carotid artery displacement by the tumor like this. So if the carotid is displaced, this part of the tumor has no artery, so you can come lateral. You can come lateral and you can work within the dura. So we described this middle fossa subgastric ganglion approach in 1995. So you see this tumor looks very dangerous and difficult, but this carotid is displaced anteriorly. This is the diagnostic implication that this is a chordoma. Clivus is destroyed, so you can work within the tumor and avoid the dural transgression, and you can remove this tumor in very quick time. So this is another tumor, preoperative and postoperative. I have just very small video presentation of this. This is, I'm working lateral. You see how the cranial nerves are under my control and how the carotid artery is under my control. And I can remove this tumor, clivus chordoma, with complete control. And if there is any damage to the artery, I can handle that damage. Imagine if you're removing from the nose and carotid gets damaged, you may not be able to handle. So this transcranial approach is also a good approach. I quickly describe supracerebellar approach from the posterior. You see this tumor coming from so far back. Lateral approach is good, there's no question. And we use lateral approach. But some cases I have approached without doing any lateral work, supracerebellar. Open the dura, identify the sixth nerve, save the sixth nerve, work within the dura, and you can remove this tumor. This is a clivus chordoma you see going in the clivus, and I did a supracerebellar and removed the tumor. So this is approach, this tumor quite in the posterior fossa. Instead of lateral approach, I used supracerebellar approach to remove these tumors. Epidermoid tumors can also be complex tumors, and we had labeled them as tentorial based tumors. They remain in the ambient system, go along the edge of the tentorium in the supracerebellar compartment. So you remove these tumors by supracerebellar approach, then cut the tentorium and go superiorly to remove the part. So epidermoid tumors, we had reported several cases of epidermoid tumor. You see this 96 cases I had reported in the year long time ago, and now we have got several hundred cases of epidermoid tumors. Pineal tumor I had reported in 2006, 24 cases. Paranasal sinus tumors are also, have a very defined dural. They are not only extracranial, they are extradural. So you have to work from the nose. Nasopharyngeal angiofibromas, you have to work from the mid-facial degloving or endoscopic approach, not from the head. We had described transcranial approach in 1994 for these tumors, but these are not for the head. They have to be removed there because they are extradural and extracranial. You have other tumors like epidermoids, which have very discrete dural relationship. We have aspergillomas which have no relationship. This fungus, if they enter and they transgress the dura because of various reasons, then they just don't respect anybody. This is tuberculoma of cavernous sinus. And briefly, before I stop this discussion, I will talk on meningiomas, which are mother tumors. They arise from the dura. They arise from mother dura. And these I have got, for several years, I'm dealing with these tumors. In 1993, I removed this tumor. 1995, these tumors. So my love for meningiomas is tremendous for several years. They are mother tumors. They are difficult tumors. They have to be understood. You cannot do it foolishly. You cannot say, I remove the tumor and I remove the patient. You have to remove the tumor and save the patient and save the function of the patient. Cavernous sinus meningiomas are of different types. This is a convex meningioma, does not affect the superior parietal sinus. This is a convex meningioma, affects the superior parietal sinus. Similarly, the cavernous meningiomas, which do not affect the cavernous sinus, are different. So this meningioma convexity is involving the superior parietal sinus, different. This tumor involves the paranasal sinus, different. It is meningioma involving the paranasal, different, more aggressive, more behavior is more aggressive. So the tumors which are inside the cavernous sinus are inherently more aggressive tumors. Tumors which are on the wall of the cavernous sinus are less aggressive. Tumors which goes inside the cavernous sinus are more aggressive. Tumors which go inside the cavernous sinus and in the paranasal sinus are more aggressive. So tumors in the cavernous sinus meningiomas are more aggressive than a meningioma which is attached to the lateral wall of cavernous sinus. You see, I had removed long time ago, and then there was a recurrence in 2001. These tumors which go in the paranasal sinus are inherently is getting supply from the lateral, not go inside the cavernous sinus. These are benign tumors, and you can remove these tumors beautifully. Posterior wall supply, you can remove these tumors beautifully, and you can cure these people. Posterior wall meningioma middles. So we were earlier removing these tumors by very aggressive exposures, but now I remove these tumors by a revolutionary approach, supracerebellar approach, beautiful for selected cases of petroclival meningioma, which I described in 2004. Many people in the world are doing selected petroclival meningiomas by supracerebellar approach. You see, this is supracerebellar approach. Some tumor is remaining here. So when to remove and how to remove. So I have got the largest series in the world in tuberculum cell meningiomas, in olfactory group meningiomas. So you can see that even from our countries, we can have very huge work, and that is our power. We should know how to deal with these tumors. We should know how to be aggressive. We should know how to be philosophical and respect the natural membranes, which are mother dura and mother arachnoid. In meningiomas, curing is not the issue. Recurrence of meningiomas is independent of extent of tumor resection. It is not the tumor, but cellular behavior that decides the outcome. We have to be philosophical, we have to be rational.
That's okay. It's just a slight delay.
Okay,
So we are slight.
my story.
Just wait. He'll come back.
Dr. John,
Yes.
the problem where? It is from Dr. Joel or from?
No, he'll come back. Just wait. Be patient. Be
Yeah,
patient.
I'm sorry I delayed you, John, because I become happy
Be patient.
when I talk, John, I become happy.
Oh, good. Okay, we're just having slight problems here.
And
So what happened?
I can operate faster than my lectures. You understand? So
Yes.
are you able to hear now? Okay, John.
Okay, you all set, Dr. Goel?
Yes, I'm okay.
Okay, do you want to take some comments or questions now, Dr. Goel?
Yes, of course.
Okay, the floor is open. Now's your chance to talk to Dr. Goel. Comments, questions?
Yes.
Go ahead.
Thank you very much. Thank you for this interesting and informative lecture about your experience. I want to ask about the tumor that extends from the middle fossa to the posterior fossa, and it's big in the posterior fossa. Is it enough to use the subtemporal approach only, or we need more approach, more stage?
Yeah. We need, in some of these cases, you can remove only from the subtemporal. Most of the cases you can remove only from subtemporal. It will depend how much it is going down, Mohammed. But majority of cases can be removed by subtemporal, basal subtemporal approach. Yes.
Okay, we have a question from Maria Laura Lafitte. Could you give any technical details about supracerebellar approach for clival chordomas, please?
Supracerebellar approach for clival chordomas, I don't recommend. I don't do in majority of cases. Clivus chordoma is an extradural entity and they should be removed extradurally. So I remove these tumors either middle fossa or by transnasal approach using endoscope. So supracerebellar approach was just as an, because we recently described this approach and I published this article in World Neurosurgery. I presented few cases, but basically I recommend either middle fossa, which is a beautiful approach. And if the tumor is extending in the paranasal sinus, transnasal approach is a good approach for clivus chordomas.
Okay, more comments, questions?
Any questions from the audience?
Go ahead. Muhammad, do you have something? Okay, we're having
Dr. for the nice teaching lecture. And I have seen, you have shown us two slides. One is touching the meningioma, in the falcine meningioma. One is touching the sinus, and one is out of the sinus. How will you deal with the one which is touching the sinus to avoid the bleeding? Is ligating is good or something else?
You know what? Sometimes my philosophy is very clear about falcine meningiomas and tumors which go into the superior parietal sinus. So if I can remove the tumor easily, sometimes you can follow the tumor and remove the tumor in the superior parietal sinus. To ligate the sinus is I do it extremely of the superior parietal sinus. I do not recommend, because you can unnecessarily create a big problem and you can have a big venous situation. But if the tumor is going into the superior sagittal sinus, you can follow and remove this tumor. To remove the tumor, you ligate the sinus. I do not recommend it. Mohammed?
Very good, Dr. Goel. Okay, I think we're ready to move on to the next speaker. Could you
Yes,
please?
I can have the next speaker, please.
Thank you. Thank you, John. Thank you, everybody. Bye-bye.
Thank you, Dr. Goel.
Thank you. Bye.
Dr. Maximiliano Sanzo from Italia, clinical aspect and surgical management of craniosynostosis. Dr. Maximiliano, do you hear me? Zahiridi. Unmute your audio.
Hello, can you hear me?
Yes.
Yes.
Okay. Well, I start my presentation. Wait for a while. Okay.
Can you do share screen? Dr. Massimo?
Yes, yes, I'm trying to share my screen.
Okay.
But I don't know how to do. Can you hear it now? I'm sorry.
Yeah.
I'm trying again. Okay. Okay.
Okay.
Can you see it?
Yes.
Okay.
That's fine.
So thank you very much to be invited in this Congress. I thank you, the President, and all the scientific committee. So my presentation is about craniosynostosis, and I will introduce it. So the important thing is to understand that the brain grows up as the school at about for a double in the first 24 months of life. So this is very important to understand the craniosynostosis. As you can see in this slide, the brain shape became more than the double in the first 24 months of year. So it could help us to understand the timing and the surgical technique for craniosynostosis. So a classification of craniosynostosis, we have primary and secondary craniosynostosis. Primary craniosynostosis, we have single suture and multi-suture. Single suture are even classified in non-syndromic craniosynostosis and plurisutural in non-syndromic and syndromic craniosynostosis. The monosutural non-syndromics are the most common craniosynostosis, like scaphocephaly, plesiocephaly, trigonocephaly, and pachycephaly. Multisutural non-syndromic are brachycephaly and oxycephaly. Multisutural syndromic are common like Cruzon disease, upper disease, Setter-Chosen disease, and Pfeiffer syndrome. Even secondary craniosynostosis that are not due to early synostosis of cranial suture are Arler and Morquio syndrome, rheumatism and hypothyroidism, thalassemia, and some drug toxicity like retinoic acid during pregnancy. It is important to understand that we need a multidisciplinary team to for the management of craniosynostosis, so maxillofacial surgeon, plastic surgeon, dentistry, pediatrics, ophthalmology, and radiology. Normally, we have this timing for the normal closure of sutures, so we can see it is about in the first 24 months of life that all cranial suture will be closed. so to let the brain grow up. It is important to understand that the cranial vault anomalies are strictly connected with school-based anomalies and orbitary anomalies. In this slide, you can see how it can change the cranial base shape due to cranial vault anomalies. Sometimes, and this is a slide in which we have a very complex craniosynostosis, we have even the school-based anomalies in that due to Chiari malformation in this case that I will explain later. So those are the most common single suture craniosynostosis in which we would have the trigonocephaly, the scaphocephaly, anterior plagiocephaly, brachycephaly, and posterior plagiocephaly. Normally, we could have some genetical abnormality in craniosynostosis. So you can see that most involved genes are FGFR, so fibroblastic growth factor receptor, 2,3 and 2,3C, and then FGFR3 and twist gene. There are, as you can see, quite involved in anterior plagiocephaly, in brachycephaly, and of course in all syndromic craniosynostosis. The indications and principle of treatment of craniosynostosis are three kinds. The first one, of course, is ICP consideration. So intracranial pressure, then ophthalmological, and then aesthetic. Of course, the principle of treatment change in the pediatric age and in adult age. In pediatric age are, in the most case, functional consideration. In adult age, it became much more aesthetic. The functional are, of course, visual loss, pain, intracranial hypertension, and airways and pharyngeal problems, especially in the syndromic craniosynostosis. Sometimes it could lead to speech problems due to deformity, proptosis, of course, and aesthetical consideration. So we start with the most common and simple craniosynostosis, that is a scaphocephaly. That is due to the early closure of the sagittal suture. And so the head will develop this kind of shape, so elongated shape, because normally the growth of the head is impossible perpendicular to the synostotic suture. So in this case, with the sagittal suture closure, we have what we call scaphocephaly. So it's like a elongated head with a prominent forehead and even occipital bone. In this, the diagnostic is just clinical, but in this slide, I show you some radiological aspect in which you can see this ridge of the synostotic suture. The surgical indication for scaphocephaly are mainly aesthetic. There are some controversy about intracranial pressure. And if there is a compensated scaphocephaly, so some is a partial suture fusion, like dolichocephaly, is not indicated any surgery. The principle of treatment, of course, are less than 6 months, from 4 months to 6 months of age is the most simple surgical treatment. After 6 months, it became much more complex. This is normal surgical positioning, so it's prone with the extension of the head. Those are the kind of incision we can perform. In the mid one, the S italic is one of the normally incision we use to perform it. It extends from the anterior fontanelle to the inium. Or sometimes you can even prefer bitragal incision or zigzag as a aesthetic problem. So this is the most simple surgical treatment of scapulocephaly. This is the stripping of the sagittal suture, in which you remove just the synostotic suture, giving in this way the opportunity to the brain to grow up, so push again laterally during its growing, and so to condition the shape of the head itself. Those are much more invasive surgical treatment, that is the cranial vault remodeling, that is now no more used. It was in the past. Or even the P. Greco technique that it's sometimes used, in which you just create an osteotomy corridor by the side of the suture and opening the anterior fontanelle. And in this way, you can achieve a good result, because you give to the brain the opportunity to grow up even laterally. And this is the imaging. Those are some examples of preoperative and postoperative in which you can see that we could have a good result, aesthetic result in scapulocephaly. Well, in the recent time, there are several new techniques, like, for example, this one, a minimally invasive approach using an endoscopic assisted craniectomy for scapulocephaly. This is our experience, in which we performed a couple of small incision anterior to the anterior fontanelle and the other one posterior on the inion, in which we performed this kind of osteotomy with less blood loss. And it's maybe the main problem for this kind of surgery. Those are some XR control. And those are the results. This one is the trigonocephaly. So it is the metopic suture that is involved. And this is the typical triangular shape of the forehead, with even other kind of implication for the skull base. Usually, so this is the normal shape of the head in the trigonocephaly, in which we get the triangular forehead. There's an hypothalamusism and even supraorbital hypoplasia. Usually this one is the incidence, so it's 1 on 15,000 live birth, and it represents about the 14% of craniosynostosis. In this study, we describe how the skull base is changed in trigonocephaly, because there is the involvement of even the skull base suture. And this is our classification, in which we have three kinds of. The type 1 is the only early metopic synostosis, just with the frontal ridge. The type 2 is early metopic synostosis plus frontal hypoplasia with the orbital ridge hypoplasia and even thickening of upslanting medial walls of the orbit. The type 3 included even ethmoidal hypoplasia and so hypothalamusism, because the involvement of the skull base. Those are the clinical aspects of the three different kinds, in which you can see how the type 3, the hypothalamusism is very important. This is the surgical technique. There is a bitragal incision, the exposure of the cranial vault, by frontal craniotomy, and then orbital ridge craniotomy, and then the remodeling. We usually turn 180 degrees the frontal bone. We create an artificial fontanelle, and then we make a construction of the orbital ridge that is, of course, remodeled, and the frontal as well. We use, in this case, of course, the resorbable plates that we put inside, and normally in 18 months, it's completely resorbed. And here you can see the intraoperative construction of the orbital ridge. And this is the preoperative image and postoperative image with a good result. Usually, as for the scientists of the bone, we use right now or biomaterial plates, like you can see here. There's polyglycolic acid plates, or even resorbable suture. Those are an example of preoperative and postoperative result. Here, another case. This one is maybe the worst monosutural craniosynostosis. Can you hear me?
Max?
Yes.
Come stai? Tutto bene?
Tutto bene, but can you hear me?
Grazie. Your time is out now.
Okay, so thank you
Caro
very much.
amico, io c'è un domanda, sì, in English.
Okay.
I wanted to ask you about the age for operation for this craniosynostosis. The ideal age for operation.
The ideal age is about 6 months, because we have the child is big enough, and we have time, and he has time for the brain to grow up. So our surgical operation will help the brain to grow up. So he has time to grow up. And so for this reason, he could have time to resolve it.
After 1 year.
After 1 year?
Yes, some authors, they told they can operate for 4 years. Is this true? I don't know about, because I remember when we were in Italy together, the ideal age in the Center for Craniosynostosis in Meyer Hospital, yes, with the Neurosurgery.
Yes.
It was from 6 months to 9 months. This is the ideal age for operation.
Well, we start, as you can see in these slides, early surgery at 4 months using less invasive technique. For example, for plagiocephalus, you can see in this slide, we use a dissection resorbable device. And so we just make an osteotomy of the involved suture till the skull base, as you can see. And so we have a good result operating this child at 4 months of age. This is what we do right now.
Thank you very much.
Thank you very much. Thank you very much to you. Thank you.
Another question for Dr. Abdul Latif.
Thank you for this lecture. My question, if our baby with brain atrophy and craniosynostosis, what is your opinion about this case?
The brain atrophy is not a craniosynostosis. It's not a primary craniosynostosis. It's secondary to the brain atrophy, and so you can do nothing, because the principle of treatment of craniosynostosis is that the brain can grow up, and so it could determine the shape of the head. Normally, the head gets the shape because the brain is inside. If no brain, no shape.
Any other questions?
Yes,
from
I
audience?
have.
Okay, because of running
I
of
want to
time,
ask.
so we'll go to next speaker. Dr. John, do you hear me? John Bennett.
Yes, yes, I hear you.
Okay, thank you. We're going to talk to take the next speaker because we are running out of time.
Okay, go ahead. Introduce the next speaker.
That's okay.
Now, this lecture for Dr. Christian Capuano, the decision making in the surgical or non-surgical treatment of degenerative disease of the spine. Did you hear me, Christian? Pronto?
Hello, we're trying to get hold of Christian.
No, now we are with Christian Cabano.
Okay, is Christian there, please?
The dissection making and the surgical or non-surgical treatment of degenerative disease of the spine. Dr. Christian Capuano.
Okay, I don't see him here.
Yes. No, he's.
Ahmed, do you see him here?
He told me yesterday he's in theater, and I think he's still there.
Okay, we may have to. We may have to have a little break here while we're looking for him. I don't see him on the panel.
We will wait for 5 minutes. If he is not here, we can go to the next speaker.
Okay. And could someone call Dr. Capuano, please?
He is not there. No answer.
I'm trying to contact him now on WhatsApp and see, okay?
Continue because Christian is not going to take the next speaker, Prof. Lewis.
Okay, John. John, you hear me?
Yes, yes, I can hear you.
We can start with Professor Louis Borba now.
Okay, he's not here. He's not here.
He's not here in the...
He's not answering, so you're going to have to go with another speaker or take a break.
I see him. I saw him in the list, or no?
Okay, is Louis here?
He's in the left.
Louis, are you here? I hope Louis is here. I don't see him. Do you see him? Louis, are you here? I don't see him. Okay, I guess we'll just take a break and try to get it together, okay? Let's take a 10-minute break and try to get it together. Okay, okay?
Okay, that's good.
Okay.
Mike. Shabab, معلش, because of time, we are going to continue with our speakers here. Dr.
Okay.
Ismail.
Okay.
Dr. John, we are going to take one of our speakers here.
That's
in our
fine.
hall.
That's fine.
That's fine, the other speakers.
That's
Can
fine.
you call Dr. to give his presentation? Dr. Ismail, are you ready?
and metallic cardiac valve. Case series. الدكتور اسماعيل اخصائي جراحه مخ واعصاب من الخريجين الجدد بورد الازمه اليمنيه.
Assalamu alaikum. Welcome everyone. I will talk about the one of the big dilemma in neurosurgery, which the intracerebral hemorrhage. Intracerebral hemorrhage induced by warfarin.
Oye, de un más pensadores de alcohol, en la boca, enjuagándose la boca toda esa huevada. ¿No? Sí.
I will talk about the management of intracerebral.
Hoy día me voy a comprar carne, ¿no? Carne de cerdo.
One of the challenging cases in neurosurgery, as we know.
Pues hagamos una comida bien chévere. Mira, yo compro pero lo voy a dejar marinando desde ahora, con cerveza. Desde ahora lo voy a dejar marinando.
And the metallic valve with and using warfarin.
¿Quién tiene orden? Los dos, pero ¿en qué casa la hacemos? La tuya. Yo digo que la de Dina, te voy a decir por qué.
During the last 4 years, we found 5 cases, 5 patients who has intracranial hemorrhage and has mechanical using warfarin. All of them with warfarin.
Sorry, we're having problems with the sound. You're gonna have to fix it.
No? Ay,
Not getting good sound. Okay, I think you may have 2 microphones open.
Hamburguesa.
Ask him to
Louis
do mute for his...
Borba's here. Okay, Christian Capuano was here.
¿Has comido hamburguesa de carne de soya?
Okay, can you fix your sound, please? And Ahmed, Dr. Borba is here.
Hello, John.
Hello, Ahmed. Make a decision. Dr. Borba is here.
If he's here, we can.
Hagamos pura comida, ¿no? Ya está.
Okay.
Ya no se nada.
Who's here? Who's present now?
I don't know. Who is running the show? Who is moderating? Ahmed, are you there? Are you there, Ahmed?
No, we have...
Okay, I suggest we stop this presentation and turn it over to Louis Borba, okay? Because technically it's not happening. Hello?
Yes.
Okay, John, you hear me?
I think we have to stop this presentation. I can't hear him at all, okay? Maybe they can present at the end, okay?
Hello, John.
Yes.
Hello. You can hear me, John?
Yes, I can hear you.
Okay. Now, Dr. Capuano, can delay him to the next session. Now we have Dr. Ismail Hodi. He'll have his lecture 15 minutes. After that, Professor Louis Borba, okay?
I can't hear you. I can't.
Louis Defer. Who's Louis Defer? Can you close your computer?
Okay, please stop the presentation. Please stop the presentation. Okay, and we'll try to do it at the end, okay? Please.
So we can start with Louis to
Yes, please.
presentations or what?
Yes, please. Louis, are you there? Louis, are you there? Louis Borba, are you there?
So ask him to present.
Yes, I'm here.
Hey, how you doing, Louis?
Hello, how are you?
Okay, are you ready to roll?
Yeah, I'm ready here.
Okay, let me just, hello, Louis. Louis Borba is a world-renowned neurosurgeon, and he was nice enough to spend time. Hi, Louis. Nice enough to come here early in the morning in Brazil and give a presentation.
Thank
and
you.
Louis, you have lots of time, okay?
Okay.
Okay, you're all
You
set.
have some microphones that are on already.
Yeah, someone has a microphone that needs to turn off. Okay, everybody mute, please. Everybody mute. I think we're okay. No, I think everybody has to mute.
There's a lot of noise, you know?
Yeah, I can hear it. Could everybody please mute? Okay, I muted everybody on the panel, but apparently there's something else here. Okay, Luis Javier, okay, okay, I think I took care of it, Luis.
Okay, good.
Is that okay?
Yeah, now it's okay. That's
Okay.
good. Somebody,
In the way.
Dr. Cristiano.
From Italy.
Hello? Okay, Luis, I think it's okay now.
I think there is just another one, Christian Cabano from Italy. He's enter and present. He's sharing his talk. Dr. John. Hello, did you hear me?
Dr. Christian is sharing
Luis,
his
are
screen.
you all set?
Yes, and there is Dr. Christian. He's sharing the screen.
Yeah, Dr. Christian, could you please? Oh man, this is a comedy of errors, Louis. Okay, Christian.
Can we ask
Christian,
to just
to get off the screen?
No problem, no
please?
problem.
Okay, I'll get it off, Louis. I'll get him off. Okay, I'll get him off.
Okay. Can I go? Okay.
Okay, there you go.
Okay, thank you so much. Okay, thank you so much. Okay, thank you so much.
Okay, I think we're okay, Louis.
Let us continue
Yeah,
with
sure.
Louis, and then we'll see the others, how we can
Okay, Louis is going to speak now, okay? Louis is going to speak now, okay? Okay, Louis, go ahead, take over.
Okay, John. Okay, John. Okay, my friends. Okay, people. Good morning, good afternoon, good night. I don't know what time is there now. Yemen. A pleasure for the first time talk to you. Now, can you see my screen?
Yes, yes.
Okay, good. Can you see my screen here, yeah?
Yes.
Okay. Good morning. I'd like to thank you all the organizing for this invitation. It's a great pleasure and honor to me. I'm calling from another part of the globe, in South America. I live in Brazil, in the south of Brazil, the city called Curitiba. This pandemic makes us stay at home. However, the teaching, the way to learn, this exchange change a lot and give the opportunity to the education to go to every part of the world. And today you can talk in the morning to the Yemen, in the afternoon to Russia, in the night to South America. Is the way that you are doing today the education. Maybe probably it will improve the patient care around the world. We as a neurosurgeon, we love what we do it. We love what to do it, and treating the patient and keep the patient without any deficit, and keep the patient with the neurological preservation is our main goal. And nothing is more gratifying than a radical removal of meningioma with neurological preservation. Who said this? Harvey Cushing. In the beginning of the last century, Harvey Cushing was the first man to say this, that it's possible to remove a meningioma and save the life with neurological preservation. And this is our goal when we treat patients with meningioma, a benign tumor intracranially that sometimes have a lot of problems with the patient. We know that the natural history of the meningioma is very strange. Sometimes you have a meningioma that you grow fast, but the great majority of them grow very slow. And also the symptoms are very slow. Sometimes you have slight diplopia, sometimes you have just headache, sometimes you have severe deficit. You have to balance the way to treat meningioma. Today we know that not all the meningioma are totally benign. Almost 90% are benign histologically and in behavior. But there is some numbers called grade 2, around 10% of the case, that you call atypical, that despite of radical removal, the tumor may come back. You have to watch very close this case. And there is the ugly one, the grade 3, the meningioma that invade everywhere, the meningioma that you remove, that you come back. And this tumor is very, very aggressive. And up to now, there is no real grade 3 treatment for grade 3 meningioma. We are happy because almost 85% are benign. If they are benign, they can be treated. This can be treated. It's in our hands to decide the best treatment for meningioma. We know today that removing meningioma is not just removing the tumor. You have to remove the bone. You have to remove the dura. You have to grade the tumor, grade 1, 2, and 3. We have to study the cytogenetic, the index, proliferative index, the hormonal expression. It's very, very important. I always say that the meningioma is a benign version of breast cancer. It's much worse in men. If you do the diagnosis very precocious, in small size, you can treat and cure. It's very important when you do this kind of treatment. We also know that the recurrence is 90% around the main mass. This is the work of Professor Borovich. He's from Uruguay, South America, but he did his work in Haifa, Israel. He saw that the recurrence was 1 to 3 centimeters from the main tumor mass. It means that you need to remove the tumor and the dura around. These should make for, especially for meningioma in the convexity. Not only remove the mass, but remove the bone, this effect, and the dura around it. As this example here, see, you have the mass down here, but there is the small baby here. And this baby here should remove also. In maybe in this area here that between the small tumor and the big tumor, also there is cells. In these cells, there are a lot of cells here. You also should remove to the tumor not come back. See, the planning is very, very important. Is the example is grade 0, the Dr. Mefti called grade 0, remove the bone, remove the tumor, and you remove the dura. See, and try to save the plan, save the brain. If you give this margin of removal of meningia of the dura, your index of recurrence will be very low. But neurosurgery and skull-based surgery in general, for this big tumor, we need a strategy. We need to plan. We need to understand anatomy. We need to plan your surgical approach. Depend of the approach you do, the way to remove. Surgical anatomy, surgical approach, this is 90% of the plan. If you use microsurgical technique correctly, is 95% of the plan. If you have intraoperative monitoring, neuronavigation, endoscopy, and a lot of stuff, it will help you to avoid complications. But it's not 100% the case that you need. If you have, of course, use. But it's not the thing that say, I cannot do surgery because I don't have neuronavigation. I cannot do surgery because I don't have a very nice endoscopy. There is plan that you can use if you know the anatomy, if you know how to approach, if you use microsurgical technique to do the surgical removal. Today, you see a lot of people talk about minimally invasive. Minimally invasive, don't need to open the head, don't need to do this crazy microsurgical techniques. It's our life. Microsurgery is our life. We train the whole life to do microsurgery. What's wrong in this surgery here? Why should we come through the nose and pull the tumor from the nose? If you can do a microsurgical technique, preserve the nerves, preserve the arteries, very short instrument. And it is the surgery and the training that we did in our entire life. Microsurgery is alive, is more and more alive. In cranial approach, you should know how to do it. Meningioma is not in the brain. Meningioma is outside the brain. Meningioma is outside the arachnoid. Meningioma, you should go around in traveling, in diving in the arachnoid. A lot of irrigation in between the veins. I always try to save the veins. Not always I can get, but you should try. We should try to remove all the veins in meningioma surgery because you don't know which vein you cause trouble for you. It's very important to use the arachnoid plane, a lot of irrigation, because the water that's coming enter between the tumor and the arachnoid, and the plane start to come. It's very, very important. Today we are in the era that minimally invasive, radiosurgery, radiation therapy, not possible to remove. But the great majority of the cases is like this, in meningiomas, not another tumors. I know they have tumors that radiation works very well. These will have cases like this. Pre-radiation therapy, post-radiation therapy. Oh, the people say, oh, very nice, control. But what changed? Almost nothing. It means that the radiation, if radiation works, give time to the patient, to the tumor start to grow is lower than was before, but does not mean that the tumor is dead. Radiation is not a definitive treatment. Radiation is a partial treatment and palliative treatment. And not every patient needs treatment. Some patient, some location of meningiomas, the natural history is much better than the real treatment. Wait and see a tumor like this, that the patient has a slight diplopia that improve with corticosteroids. Maybe wait and see. If the patient has no real vision deficit, should wait to see what's going on. But you cannot do like this. When you go to the largest meeting in the world, in the United States, you see the propaganda from Gamma Knife Lexel. See, this tumor to treat with radiosurgery, radiation therapy. Oh my God. This is the simple case in the posterior fossa. Look at the attachment here, see? You cannot lie to the patient. You cannot say to the patient what you have the tool that you have. Should use the tool that the patient needs. It's the most important message you should have. Look the case here, if the video is running, you can see here in the posterior fossa, here's the cerebellum sitting position. We cut the insertion, the attachment of the tumor in the tentorium. The same situation that the propaganda for Gamma Knife. Okay, you killed. Now the tumor is dead. See, you can come and you can just remove the tumor, just a big football ball. See, this big ball, we remove the tumor, was in deep position. The patient's cured. No more radiation, no more any kind of treatment. I know that there is a situation that you should use radiosurgery, but not to every case. The people say, I must buy a Gamma Knife. My country should have a Gamma Knife. My country should have a big machine to treat it. Maybe our country needs microsurgical training. Training the people learn in the pre and the post-op. We know that the radiation, you have some complications. Looks like, oh, no problem. Give Gamma Knife. No open the head. Go home same day. In the afternoon, you can play football. But the time you give you the complication, epilepsy, hypothalamic dysfunction, cognitive impairment, 7 more times stroke than a normal patient, visual deterioration, and new tumors. Radiation-induced meningioma is the worst meningioma. If you see this picture here, after the Second War, many people, especially the people from Russia, the Jewish people that was in Russia, was going back to Israel. And they have tinea capitis, a lot. How to treat? They use very, very low doses of radiation therapy. What's happened? Radiation-induced meningioma, the worst tumor. Use the tool. Use the tool when the patient needs. Don't use the tool because you just have the tool. It's the most important message you can say. There is one area today that the people say that is impossible to touch, you cannot do. It's in the base of the skull. It's close to the brainstem. This area they call the petroclival area. This area is an area that is this here. Sigmoid sinus, internal auditory meatus, trigeminal nerve, clivus, petrous. If the tumor arises here, what's happened? Start to grow. The patient start to have symptoms, and this patient will die. This patient need treatment. Sometimes you need skull-based approach. Sometimes you need a simple retro-sigmoid approach. I'll tell you, 90% of the tumors in the skull base, you can remove by pterygium approach from here and retro-sigmoid approach from here. 90%. In 10%, you need cranio-orbitozygomatic or petrosal approach. But you need, if you need, you should know. If you don't know, you should go to the lab or go to try to learn, to do the best to your patient. Neurosurgery, you need exposure. Don't make a small hole and try to get the tumor from the small hole. Expose. Show everything that you want to see. Don't look from the loop. Look from the big picture. The big picture will help you a lot. But the people come back and ask me again, I say, why to remove this tumor? This patient here in the middle has just diplopia. You know why to remove? Because of this. When you have brainstem edema, this patient will die. This patient will have problem. Here it almost game over. Treat when you can help. Don't leave to treat after you have a lot of complication. The possibility to the patient to improve will be much, much less. We call petroclival area the area that is in the clivus, is in the anterior petrous here, but not in the tentorium. If you go to the literature today, you see a lot of people talking about petroclival meningioma, which is a very simple approach. But the great majority of the cases are not real petroclival, are meningioma for the tentorium, as the case that I show. That is very simple, is very different. Today we have 4 kinds of approaches. Some people want to use from the nose, the classical retro-sig, the posterior petrosal, the anterior petrosal. The endonasal that now is popularized, coming from the nose, no need to open the head. They say that the limit is the 6th nerve. 6 nerves here. See? Here and here. What's happened? 8.8 millimeters. It means that you can remove very small tumors like this. But the great majority of people that we see in South America and you see in all the continents, in Asia and Africa, not this. It's like this. And sometimes the tumor is like this. How you can remove through the nose this? You just go there and bite, not do the real surgery. You need to learn the way to reach the area. To reach the area, you can come from the middle fossa. Here's the peeling of the middle fossa, you call. Here's the petrous apex. You remove this part, just peeling the dura. We expose this area here. You come from lateral. It's a very simple way to treat. And this guy in China with 1,546 petroclival meningioma, he used in more than 50% of the case, he used transpetrosal approach. It means that you should learn temporal bone. It means that you should go to the lab to learn temporal bone. And the lab, you don't need to go to US. You don't need to go to Europe. You don't need to go to Brazil. You can do in every part in the world. Go to the anatomy department, that very old cadaver, no? You can go there and train. You are there not to make nice pictures. You are there to learn and to help the people. The anterior petrosal give you this route for you, the subtemporal. See, here's the basilar artery, here's the third nerve, this was the tumor. And for this hole here, this space that was given here, see, the basilar here is this space here. See, same space. This is the space that you use to remove the tumor. And the pre-op and the post-op, you can get it. And depend of the size, depend of the location, you use this highway. If you use this highway, subtemporal, extradural, from outside to inside. It's very important to follow. But there are situations like this, you should study not only the tumor. As I said in the beginning, you should study the veins. Look at this case. Maybe this case would be a good way to approach. But look at this. There is no communication between the sinus, and the tumor was in the side of the only sigmoid sinus. If you do remove this, if you damage the sinus, the patient is dead. You see the situation here? Tumor this side, you are working this side. If you have some problem, I will have to be prepared. No? If something happens, we need alternatives. In this situation, we choose to come from here, midline also, see, to remove the mass, because you couldn't come from the lateral. But the workhorse is this, the retrosigmoid approach. You come from posterior here, the simple way, in the CP angle. The same way if you do acoustic, you can do some meningioma in the posterior fossa. I have cases like this. Look at, oh, petroclival meningioma. No, it's not petroclival meningioma. The insertion, the attachment of the tumor is down here. See? If you come from here, very simple, retrosigmoid approach. And just follow the tumor. Inside the tumor, you then don't need to remove the temporal bone. Very simple approach that you do every day. What's the most important in this situation? See, the main attachment of the tumor was here, between the lower cranial nerves and the facial nerves. See? To define, see, where was The attachment, where is the attachment of the tumor? From where the tumor came. It's the most important thing. The tumor came from here. Okay, let's approach from here. The tumor came from the tentorial. Let's approach the tentorial. It's the most important thing when you decide the surgical approach. It's the pre-op, the post-op you can get. There are situations that you can use retrosig, the simple retrosig they used to do, and you can use Petroso approach. Remove the temporal bone. You can decide. Maybe I use more Petroso approach than you use. Don't know why? I'm used to do it. I do fast, I do safely, I train. Maybe in situation that I will show you now, that I use Petroso approach, you can use retrosig. Example is like this. It's a tentorial meningioma, very large tentorial meningioma. You can come retrosig, you can cut the tentorial, you can remove for the posterior fossa. But why I did Petroso approach? I did Petroso approach because the insertion in the attachment and the blood supply to the tumor was coming from here, from the tentorium. If I do the Petroso approach through the press sigmoid, I cut the vascularization of the tumor, and the tumor will be dead. I can remove this big mass in piecemeal, bloodless. It's very important in neurosurgery. See, another situation like this, the people say, oh, you cannot remove this tumor without this part here. It's in the cavernous sinus, very dangerous. It's not cavernous sinus. You call Meckel's cave. Here's the fifth nerve. You come here, you just follow the tumor. In this situation, come press sigmoid, retrosigmoid. We use all the roots. If you have doubt which approach to use the larger one. The large one gives you option. Here's the fifth nerve. See, from the posterior fossa to the middle fossa. Here's the fourth nerve. If you have doubt, use the large one. If you don't need, it's okay. The worst situation that you need the space, you don't have it. If you do large approach, you can do this way. Maybe you need, maybe you don't need. You don't need, it's okay. But it's very important to have this concept. Lose a little bit of time to prepare. I always give as example. If you want to do fast food, we'll go to McDonald's. You go there, take the food, eat, and go. Fast. Quality. Maybe some people like it. I love it. I know, but some people like it, some people don't like it. Sometimes you need. But you want a very nice food. A good food. Prepare with care. Prepare with time. And enjoy your meal. This is the difference when you do neurosurgery with passion, when you do neurosurgery with love and dedication. Give your time to save the life of the patient. Tumor like this, give 1 day of your life to save the life of this patient. Don't try to come very small hole. Just bite a little bit and go home. You're not helping the patient. We are doctors. We are here to help the people. We are here to try to save the lives of the people. We should not be worried about time. We should not be worried about Oh, I don't have time to stay so long. I have to go to the office. I have to go to somewhere. Give your time to save the life of your patient. It's your main goal as a doctor. We should go to the lab. We should train. We should do the training in the laboratory. This here is in Yemen, in Russia, Siberia. Is a very nice lab of Professor Sufyanov. It's close to you. Maybe you could go there and train Professor Sufyanov. We are go there every year, do our course. Very nice facilities, open to the whole world. Maybe the people of the Yemen come there to train. If you go there, go to the lab, go to surgery, you do safe surgery. If you learn in the lab, you can do this approach. Large approach, but multiple routes. Is left side, retrosigmoid, pressigmoid, subtemporal, multiple routes. In the time you decide which route, which highway you use to remove the tumor. I go faster here. I have case like this. This patient has diplopia, 6th nerve palsy, very, very large tumor. You should go there to the surgery, remove, save the arachnoid to the vessels, leave the vessel intact, the 6th nerve, the 5th nerve, and the post-op, the patient be like this. The patient happy, you are happy. 1 day work, 1 day surgery. But this is the price to save the life of this patient. You could tell, oh, the 6th nerve didn't prove. 6th nerve palsy for this large tumor is a very high price. You believe that is very high price to save the life and maybe do an ophthalmological treatment to repair this deficit. This patient was dead with large tumor. Now this lady has his life totally safe. Let's think about this. Or another situation like this, large tumor, brainstem edema. We did the surgery, removed the tumor, and the patient had 4th nerve palsy in the post-op. That you can correct with glass. Is a high price? I don't believe. I don't believe. See, you save the life of the patient. But there are situations that to remove the tumor is high price. A situation like this is a man, a tentorial meningioma, and a foramen magnum meningioma. We did the surgery, but there was no plan to remove the tumor from the lower cranial nerve. If I try to remove this small piece that was here, there was no plan to dissect the tumor from the lower cranial nerve, the patient will have problem. The problem have swallow, maybe tracheostomy, maybe gastrostomy. It's high price. In this situation, we prefer to leave a small piece of the tumor attached to the nerve, around the nerve, and just follow. Maybe in this situation, if the tumor starts to grow again, you can give radiosurgery. It's important to understand our limits. It's important to understand that you are doing the surgery, we are doing the treatment for the patient, not a trophy for the surgeon. It is very, very important to have this concept. in your mind as a doctor. I want to finish the presentation, show you this.
Okay, thank you.
See, you have to train, have to go to the lab. Is the best way to learn is go to the lab, train. Don't train in the head of your people. Don't train in the head of your patient. Go to the lab. We need commitment. Need to be everybody together. We need to do a teamwork. We need all the people together in this field. I thank you all for listening. It's a pleasure to be here, and I'm happy to be here. Thank you.
For discussions, questions, and comments. Shabab, any questions,
Thank you.
any comments? The elegant, very informative talk. We have great information. Thanks a lot for you.
Thank you. A pleasure.
Thank you, Prof, for your nice and nice lecture. I would like to ask you, what about cavernous meningiomas? Your opinion, especially when the patient has neurological deficit.
Has no neurological deficit?
Have you got?
When the patient
has
deficit or
progressive neurological deficit.
So you have two situations in cavernous sinus meningioma. When the patient has no deficit and there is a small lesion, the patient has no deficit. See, if the tumor is small, located just in the quest, just in the cavernous sinus, you can wait and see. Don't send to radiation, don't do surgery. Okay? No deficit. The natural history of cavernous sinus meningioma is benign, is much benign than we believe. Second option, if the patient has no oculomotor deficit, but has vision loss, optic nerves, okay? You should go there, do the peeling of the middle fossa, and decompress the optic nerve, okay? The third option, if the patient has oculomotor deficit, severe oculomotor deficit, and the mass, you can go there, remove the tumor, and try to save the nerves, if you recover or not. Fourth option, if the patient has ophthalmoplegia, complete ophthalmoplegia, it means that will never more will recover. Will not recover. Now you have the option to go there and remove totally, save the artery, and done. Or you remove the maximum mass and irradiate the remaining tumor. Cavernous sinus tumor, meningioma, no meningioma, meningioma, cavernous sinus meningioma, you should be very, very, very conservative in some situation and aggressive in another situation. But the most important is to know that these tumors are benign and very slow growth. Okay? I answered to you?
Thank you. Thank you very much.
Any other questions?
This is your chance, gentlemen and G-men.
Okay, thanks. There is no any other more questions. I have to thank all the participants, all the speakers, starting from the Prof. Lewis, Dr. Massimiliano, Prof. Util Joel, and Dr. Asim. Thanks a lot for all of you. Hoping to see you back again in next sessions. Thanks a lot.
Thank you. Thank you. Appreciate it. Thank you, John. John,
Okay,
thank you, John.
it took a while to get you here,
Yeah.
Louis, but you got here.
Okay, thank you. Thank you. Thank you, sir. Thank
Thanks
you.
for coming. Thanks for coming.
Thank you. Thank you. Bye-bye.
Bye.
افتح من كده ما في. شكرا لكم جميعا.
Time for
Wow, there's a lot of people there in the auditorium. I'm featuring you on the. Who am I speaking? I'm Dr. Bennett. To whom am I speaking? Wow, that's great. That's great. Okay, do you have a
Hello, John.
microphone there? Do you have a microphone? No.
You hear me, John?
Yeah, I hear someone.
It was very nice lecture. Thank you to
Yes.
Professor Lewis.
Yes.
Very nice, very informative lecture. Now we will have a 2 hours break, okay? And we come back after 2 hours.
Okay. Okay,
Okay,
very
thank
good.
you.
I'll see you in 2 hours.
Okay, thank you very much.
I'm just going to leave the room open. Okay.
Okay.
Wow, that's a lot of people in the auditorium, huh? Now, who are these people in the auditorium? The neurosurgeons, students, or?
Yes, most of them are neurosurgeons.
Wow, that's a lot.
Residents and specialists.
That's a lot.
More than 300 people.
So they're hearing everything? They're hearing everything?
Yes, we are hearing everything.
They're seeing everything too? They're seeing everything?
Yes, it's all in the projector. وريها projector. It's وريها projector. شوفها projector. Everything are in screens and in projector. Everything
Let's see. Let's see.
watch. They see
Wow.
everything.
Wow. So that's great. So the resolution is okay? The
Everything
picture
is
is
great.
good? The picture is good?
And fantastic.
Great.
One of the best Yemeni conferences until now.
Great.
Okay, see you in
Well,
2 hours,
you know,
John.
I didn't think Louis was going to come.
Yes, me too, until the last second. But
Yeah,
it
that was nice of him to come.
His lecture was fantastic. He's a real master.
Well, you know, I've seen him lecture in Russia. Matter of fact, we televised him from Sufyanov's Yemen that he was talking about. Did you hear that? Talking about that?
About Russia.
Yeah, he gives great lectures there, and there's not many students. There's only 20 students, but he still takes a lot of time and teaches well.
He's a real master, and he has a very nice lecture, really.
Good,
I'm
yeah,
a big
good quality lecture you got there.
the best quality lecture.
Okay, yeah.
Now here, all the Yemeni neurosurgeons are here in this auditorium. If something happened, there will be no other neurosurgeons in Yemen. Okay, John.
Thank you.
See you in 2 hours. See you in 2 hours, okay?
Okay. Okay, okay, everybody, we start again in an hour and a half. Okay. Please, please, please mute yourself, please.
And this unedited to deal with.
Wait for 5 minutes.
For end and then that's it.
In the auditorium, huh? Now, who are these people in the auditorium? The neurosurgeons, students, or?
Yes, most of them are neurosurgeons.
Wow, that's a lot.
Residents and specialists.
That's a lot.
More than 300 people.
So they're hearing everything? They're hearing everything?
Yes, we are hearing everything.
They're seeing everything too? They're seeing everything?
Yes, it's all in the projector. What a projector. It's what a projector. Show a projector. Everything are in screens and in projector. Everything
Let's see. Wow. Wow, sure, that's great. So the resolution is okay? The picture is good? The picture is good?
And fantastic.
Great.
One of the best Yemeni conferences until now.
Great.
Okay, see you in 2 hours.
I didn't think Lewis was going to come.
Yes, me too, until the last second. But
that was nice of him to come.
His lecture was fantastic. He's a real master.
Well, I've seen him lecture in Russia. Matter of fact, we televised him from Sufyanov's Yemen that he was talking about. Did you hear that? Talking about that?
Russia.
Yeah, he gives great lectures there, and there's not many students. There's only 20 students, but he still takes a lot of time and teaches well.
He's a real master, and he has a very nice lecture, really.
Good quality lecture you got there.
Best quality lecture.
Okay, yeah.
Now here, all the Yemeni neurosurgeons are here in this auditorium. If something happened, there will be no other neurosurgeons in Yemen.
Okay, John.
Thank you.
See you in 2 hours. See you in 2 hours. Okay.
Okay. Okay. Okay, everybody, we start again in an hour and a half. Please, please, introduce yourself, please.
And this unedited to deal with. Wait for 5 minutes for end and then sit.
In the auditorium, huh? Now, who are these people in the auditorium? The neurosurgeons, students, or?
Yes, most of them are neurosurgeons.
Wow, that's a lot.
Residents and specialists.
That's a lot.
More than 300 people.
So they're hearing everything? They're hearing everything?
Yes, we are hearing everything.
They're seeing everything too? They're seeing everything?
Yes, it's all in the projector. What a projector. It's what a projector, super projector. Everything are in screens and in projector. Everything
Let's see. Wow. Wow, sure, that's great. So the resolution is okay? The picture is good? The picture is good?
And fantastic.
Great.
One of the best Yemeni conferences until now.
Great.
Okay, see you in 2 hours.
I didn't think Lewis was going to come.
Yes, me too, until the last second.
Yeah, that was nice of him to come.
His lecture was fantastic. He's a real master.
Well, you know, I've seen him lecture in Russia. Matter of fact, we televised him from Sufyanov's Yemen that he was talking about. Did you hear that? Talking about that?
Russia.
Yeah, he gives great lectures there, and there's not many students. There's only 20 students. But he still takes a lot of time and teaches well.
He's a real master, and he has a very nice lecture, really.
Good quality lecture you got there.
It is quality lecture.
Okay, yeah.
Now here, all the Yemeni neurosurgeons are here in this auditorium. If something happened, there will be no other neurosurgeons in Yemen. Okay, John.
Thank you.
See you in 2 hours. See you in 2 hours, okay?
Okay.
billion-dollar coaching company with just one 45-minute presentation? Look, if you're an How would you like to help local businesses and get compensated very well, all without ever leaving your own home? Hi, my name is Chance, and I'm feeling extremely grateful right now. A little over 4 years ago, I started building a simple offices business agency. Now, I operate this thing from my own home, which means I get to spend all the time in the world that I want with my family. And each month, I get paid by over a dozen real businesses just for helping them run simple online ads that make their phones ring with real customers. And in my opinion,
While you were hanging yourself.
Hey, do you want to know how we built a $50 million coaching company with just one 40?
Soft-spoken with broken jaws. Step outside, but not to brawl in. All the sweet wind, call to fall out. Make it to the moon, never have to crawl in. With the birds and share, it's a lonely view. With the birds and share, it's a lonely view. With the birds and share, it's a lonely view. How long will I slide? Separate my side. I don't believe it's fair. Slitting my foot is all I am. Looking for a truth for a brand. I thought it up and brought up the past. Once you know, you can